Chapter session for, okay. Well, welcome everybody to our Africa Chapter EcoHealth International Summit session. We welcome all of you. Thank you for coming, for taking your precious time to come and be with us. Before we do anything, let me just give this time to Dr. Mutero to serenade us with something wonderful. Over to you, Dr. Mutero.
Thank you, Dr. Halase. So, colleagues that who are not familiar with the Mbira music from Zimbabwe, it's unfortunate I can't see myself, but I hope we can see the instrument. Is my video showing?
No, it's not.
It's not.
There you are.
Jesus. You see me
I
now?
think you are hiding it with something. I saw you for a brief second and you disappeared. There you are.
Okay, so I turned the camera off unknowingly. All right. So this instrument is called Mbira and it's from Zimbabwe. I'm going to play a song called Vano Kaliwa. And I'm not going to sing. You make up the song.
Sound is coming out? No sound?
We can't hear you, Dr. Mutero. There's no sound.
Even now?
No.
So you can hear me as I speak, but the Mbira you can't hear it.
Yes.
Maybe because of your
From the last
headphones?
time, I think
Okay, let me
it
tell
was
you.
to share even the media.
There's also a setting in your audio for music.
I work out now. Can you hear it now?
No, we can hear you, but not the music.
Ladies and gentlemen, unfortunately, the show today seems not to allow me to play the instrument. But on another day, I'll play it for you.
Well, I hope you will actually fix it. So at least before we are done here, we would have heard what you wanted to share with us.
Yeah.
So with that said, it's unfortunate we aren't able to listen to that. But I believe, as I've said before, we are done, we would have heard something. Let me greet you once again as we officially start our session as the Africa chapter. And at this particular point in time, let me just let you know who I am. My name is Halase Ramolefe, and I work for the University of Botswana, and I am an early career researcher or representatives for the Africa chapter. Today, I'll be your facilitator for the entire session. And I'm working alongside Dr. Mutero here and Dr. Chester Kalinda, as well as the other ECRs all over the globe. You are welcome and thank you very much. And at this time, please let me give this chance to the EcoHealth International President, Dr. Professor Chimbari, who is a professor of public health and a president for EcoHealth International. I'll give you this time to take us through the opening remarks, the welcome remarks, as well as the summit introduction. Over to you, Professor Chimbari.
Thank you very much, Dr. Ramolefe. Good morning, good afternoon, and good evening, depending on where you are. It is my pleasure as the president of the EcoHealth International to open this 4th edition of the 3rd annual EcoHealth Global Summit that we commonly refer to as the Earth Hug. Let me be upfront and say this is an initiative of the EcoHealth International Youth Wing, the early career individuals who are the future leaders of EcoHealth International. I want to acknowledge the leadership of Angel Kennedy and the regional nodes for driving this agenda in the past 2 summits, and indeed the current one. EcoHealth International was launched in 2006 at Madison in the USA as the Association of Ecology, an Association for Ecology and Health, abbreviated as IAEH. In 2016, the association changed its name to EcoHealth International and transformed into a regional driven association with the establishment of 5 chapters, namely the Africa chapter, America, Asia, Europe, and Oceania. This transformation did not change the aim of promoting eco-health approaches that place human and animal health in the center, exploring all possible factors contributing to the health problem and interactions between the factors. The eco-health concept is premised on 6 pillars. The systems thinking pillar, which recognizes the complexity of the challenges that we are faced with. Transdisciplinarity, which provides the expertise to deal with a complex problem. Stakeholder participation, which is essential to get buy-in from all stakeholders. Gender and social equity, which ensures that no one is left behind. Knowledge to action, which actually transforms what we do into real action so that we solve real problems. Sustainability, making sure that systems roll on their own without outside interference. Within those 6 pillars, we value diversity that is reflected in our structural makeup. We leverage on our shared values based on the equity and diversity of our genetic makeup. We have genuine collaboration and partnerships for tackling socio-ecological and health-related problems. And we have a common home for all diverse groupings. No one and no place is left behind. And most importantly, we work towards a sustainable planet Earth for the next generation. Through our early career individuals movement, it has been possible to make our vision more visible through the theme of this global summit, which is working together for a healthy, just, and sustainable future. In this 4th session of the Global Summit, the Africa chapter will deliberate on experiences in advancing gender equity, social inclusion, and well-being in integrated approaches to health. This discussion builds on the dialogue that has already been initiated in previous sessions in the Middle East, North America, and Oceania of the 3-day journey of connecting across the globe for a common cause, which is about good health, justice, and a guaranteed sustainable future. I therefore welcome you all to a great interactive session about to kick off. Thank you very much.
Thank you very much, Prof. Chimbari, for that introduction. Everybody feel welcome as we are getting ready to indulge in the conversations about the themes which we have. The main overarching theme being working together for a healthy, just, and sustainable future, followed by the Africa chapter theme, which is gender and social equity and well-being outcomes, advancing gender equity, social inclusion, and well-being in integrated approaches to health. And this is just acknowledging the fact that health problems actually are often experienced differently by different social groups. And therefore, whatever we do, we must ensure that there's equity in addressing the needs of the marginalized population. So I'm looking forward to hearing what all the speakers have to say to these themes. And next on the agenda, we will have Professor Nyepi, who is a professor of human nutrition and an EcoHealth International Africa chapter chairperson. So I'm going to give her this time to be able to introduce to us the keynote speaker of today. Over to you, Professor Nyepi.
Good morning, colleagues. Good morning, everyone under the audios of my voice. I want to believe that I'm quite audible. It is indeed my privilege this afternoon to welcome a very experienced colleague in the name of Amelia Pelt, who is a senior gender advisor at the United States HIV/AIDS agency. She is highly experienced and has had the opportunity to work across continents with the sole purpose of advancing gender equity initiatives in developing countries, in the area of policy, in terms of action research. Her leadership has been even experienced by many of us in sub-Saharan Africa, as we got the opportunity to see a lot of the work that she has driven. And a number of donor agencies have also worked with her. She has been a consultant in a number of areas. And in fact, it's important to recognize that she has been in the area where she was particularly concerned about issues of nutrition, which are close to my heart, in the extent that they affect women and children. She has worked with a number of governments as she consulted as a technical advisor in this space. It's indeed an honor to see her this afternoon and to be under the audience of a wonderful presentation that I truly believe it will be, given the track record that is quite clear when you look at her words and her works. I think one of the beautiful things is that her presentation will help us appreciate the transdisciplinarity that is so interested into EcoHealth methodologies, and the fact that a lot of her work, she has had to work with a diversity of professionals. I do not want to take a lot of time or even steal her thunder, because she is a woman of great repute. Thank you so much for agreeing to grace this event. We look forward to hearing you. With those few words, we really would like to hear from you, and you can take this podium. Thank you.
Well, thank you so much for that very kind introduction. I'm very flattered. So good morning, good afternoon. I'm sending my warmest greetings to you all. My name is Amelia Pelt. I use she, her pronouns, and I am truly delighted to be joining all of you today. Thank you so much to the organizers of this event. Thank you, Dr. Chimbari, for your excellent opening remarks. Thank you to Dr. Nyepi for your very, very kind introduction. I hope I don't disappoint. Thank you to Dr. Chesta Kalinda, to Angel Kennedy for the invitation to speak. And a special thanks to my very dear friend and colleague, Dr. Jackie Chirura, who encouraged me to share some thoughts with this esteemed gathering. So thank you to all the participants for joining us today, and allow me to say all protocol observed. So I'd like to begin my remarks with an Indigenous land acknowledgement. I am living and working on the traditional and unceded territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land that I live upon is called Toronto, or Takaranto, which in the Mohawk language means where there are trees standing in water. I offer this land recognition as an acknowledgement of the historic oppression of the lands and the cultures and the original peoples living in the land that we now know as Canada, and that inequality and racism, an enduring legacy of colonialism, persist today. By making this land acknowledgement, I hope to make a small gesture towards reconciliation and to honor Indigenous heritage so that we may live in right relations with each other and together care for the land that we all call home. So as we've heard, the theme of the Africa session of the 3rd Annual EcoHealth Global Summit is gender and social equity and well-being outcomes, advancing gender equity, social inclusion, and well-being in integrated approaches to health. This is a topic that's not only near and dear to my heart, but one that has tremendous global urgency today. There are several themes around this topic that I wanted to discuss today, but first let me tell you a little bit about my background so that you can know me and the perspectives or the biases that I bring to the ideas that I'm going to be sharing today. So for almost 25 years, I've worked in the global health, international development, and humanitarian response industry. Yes, it is an industry that, despite its many flaws, has, I believe, also done much good in the world. I've worked throughout Africa, the Middle East, and Asia in health, education, economic empowerment, food security, water and sanitation, but always with the aim of advancing gender equality and ending gender-based violence. For the first 12 years of my career, I was working with international and local non-governmental organizations whose missions were to improve the health, education, and economic well-being of individuals, families, and communities. The second part of my career, what I've been doing, or what I did for the past 14 years, was spent at the United States Agency for International Development, or USAID. And I was working in the Office of HIV/AIDS on the PEPFAR program. And I was the global technical lead on gender equality, gender-based violence, and HIV. Unfortunately, I was one of the hundreds of USAID staff members who lost their jobs earlier this year as a part of the radical destruction of the agency and the dismantling of US foreign assistance. And I really loved my job. But despite the many problems and challenges, I got to work alongside some of the smartest and most talented colleagues across the globe who devoted their life's work to ending the global HIV pandemic that has claimed so many millions of lives. So while I now find myself unemployed, temporarily, I really do hope, the time it's given me is a moment's pause to think about what we have collectively achieved. What have we learned, and what we, this wonderful global community of all of us together, must continue to do to achieve health equity and gender justice for all. So this brings me to the themes that I'd like to touch on in my remarks today, which I hope will also speak to the framing questions for the Africa session today. The first is that achieving sustainable development and realizing a world where gender equality and health equity can flourish are mutually reinforcing goals. The second is that gender equality and health equity are not only possible, but they are urgently needed. And third, transforming the world into one where health equity and social justice is realized means embracing feminist principles and living them out in our daily lives. So to go to this first theme that I'd like to talk about is this notion that achieving sustainable development and realizing a world where gender equality and health equity can flourish are mutually reinforcing goals. They're not at odds with each other. On the contrary, they depend on each other. Now, while this may be obvious to every single person gathered here today, if I had to guess, I would say that every single person in this virtual room has had to advocate for including gender equality as an outcome of sustainable health and development programs. I am sure that you have had to say, and we can tell stories about having to say to someone, look, how can we realize our goals of reducing child malnutrition and maternal mortality, or improving sexual reproductive health, or ending a pandemic, be it HIV or COVID or tuberculosis, without addressing the structural and gender inequalities that allow these problems to flourish. How often have you been told, sure, I understand. Gender equality, it's a nice secondary benefit, but the real goal is X or Y or Z. Such sentiments diminish the importance of intentionally addressing gender equality and health equity and fundamentally misunderstand the relationship between inequality and poor health. The social determinants of health, including poverty, gender inequality, violence, homelessness, mental health, stigma and discrimination, particularly against our LGBTQI+ brothers and sisters, marginalize and make vulnerable our individuals, families, and communities, and make them much more susceptible to poor health and vulnerable to external shocks, such as disasters that are brought on by the global climate emergency. The second point that such arguments miss is that sustainable development efforts that intentionally and explicitly address these social determinants of health have a much greater chance of not only achieving their program objectives, but sustaining long-term positive impacts. We can further focus on gender inequality as a social determinant of health to address one of the framing questions posed for today's session, which is how do gender and social equity shape health outcomes, especially in marginalized communities? The root causes of gender inequality are numerous. Harmful patriarchal norms that devalue women and girls and gender and sexual minorities, homophobia, transphobia, stigma and discrimination, acceptance of the use of violence, particularly intimate partner violence and violence against children, weak laws and policies protecting human rights, shrinking democratic spaces, which unfortunately we are seeing across the globe, and poverty and illiteracy. There's a tremendous amount of data illustrating these manifestations of inequality, including maternal, infant, and child mortality, widespread gender-based violence, diminished sexual and reproductive health and rights, high rates of HIV transmission and poor HIV viral suppression, and greater burdens of pandemics and infectious disease amongst those who have been made most vulnerable in society. Change is possible, and I'm going to talk about that today as well. But there are still significant obstacles to realizing health equity, gender, and environmental justice that must be overcome. Underpinning inequality is patriarchy, the system that consciously and sometimes subconsciously prioritizes cisgender men's power, perspectives, and needs above all others. Gender is not just about women and girls or boys and men. It's about power and it's about control. It's about how we define people in relation to one another. And usually that relationship is defined by a power imbalance. One of the starkest reminders of this in recent memory was the COVID-19 pandemic. At the start of the pandemic, if you remember, the sentiment that was often expressed was, we're all in this together. But it quickly became evident that this supposed equity of risk was born in the most inequitable of ways. What on the surface looked like cracks and fissures within our society quickly revealed themselves to be great chasms of inequality that pushed those that had already been vulnerable further to the margins. Simply put, the COVID-19 pandemic set health equity back decades. Progress on gender equality was undone seemingly overnight, which was quite evident in the stark and rising unemployment statistics, particularly amongst women, the increases in domestic and intimate partner violence and violence against children, the erosion of fundamental human rights, and they were all borne disproportionately by women and individuals across the spectrum of gender identity, but particularly LGBTQI+ individuals. These are significant structural inequalities that the pandemic exploited to further its spread, but they're also not impossible problems to solve. We have policy and program approaches that we know can address inequality, violence, stigma, discrimination, and I'm going to talk about some of those. But before that, I feel that we truly needed to reckon with what the COVID-19 pandemic did to individuals and families and communities. Inequality was ignored. It was swept under the rug as people raced to, quote, return to normal. But what is normal after a pandemic? And was normal really working for everyone? Maybe it was working for some, but it was not working for all. So the question really becomes, why would we not address gender inequality in our public health and sustainable development efforts? In the face of the harms that inequity and inequality cause, we cannot ignore the reality that achieving sustainable development and health for all can only be achieved when we put equity and equality at the center of our efforts. As the late and great Dr. Paul Farmer said, medicine should be viewed as social justice work in a world that is so sick and riven by inequalities. The second theme that I'd like to address today is that realizing gender equality and health equity are not only possible, but they are urgently needed. Our wonderful global health and gender community has a growing body of evidence about what works and what doesn't work to not only improve health outcomes for better equity, but how to prevent and respond to violence against children and women and LGBTQI+ individuals, and how to enact change. It's important to remember that gender is not just about men and women or boys and girls or transgender individuals, as I noted a moment ago, but how these identities are defined in relation to one another. Because gender is really about power disparities. It's about control, it's about access, it's about representation and visibility. It shapes the roles and the responsibilities, the entitlements of women and men and boys and girls, people of other gender identities. So in order to address these root causes and structural barriers that contribute to poor health, it's essential to situate our work in this relational concept of gender. Such an approach is more inclusive and centers the focus on inequalities and power disparities, which are the essence of addressing gender equality and health equity. In the Bureau for Global Health at USAID, where I worked prior to its destruction, crafted several goals and objectives that articulated its vision, our vision for gender equality and global health. And in preparing these remarks today, I was looking back on these notes and these ideas, and I'm probably biased, but I still think that they are a good articulation of how health equity and gender equality are not only interrelated, but achievable in our lifetime. So I wanted to share these with you today. The first of these goals was that advancing gender equality and ending gender-based violence is essential to sustaining health outcomes and creating a healthier and more equitable world for all people. The second goal was promoting the human rights of women and men, girls and boys, LGBTQI+ individuals, and those of other gender identities of all ages and all abilities is essential for people to utilize quality health services, to be able to practice healthy behaviors and build equitable relationships at home and in the community, to exercise their rights, and to live lives free of violence and stigma and discrimination. And the third goal was to build strong and resilient health and social service workforces and systems that are responsive to the needs of diverse populations. I still believe these are important and achievable goals in our lifetime, and hopefully they can be picked up and carried forward now by others. These goals that we had envisioned were resting on several important approaches, and these included gender transformative social and behavior change efforts, preventing and responding to gender-based violence, designing and delivering more gender-responsive health services, advocating for laws and policies that advance equality, and helping to build a diverse and equitable health and social service workforce. What's important is that these represent a range of different kinds of programs and services and policy efforts that are intentionally designed to close gaps and address inequalities that have been talked about earlier in order to improve health and well-being for all. Hopefully, what's also clear is that working towards gender equality and our global health outcomes are not two distinct or unrelated goals, but are inherently connected to each other. Progress in one can't be achieved without progress in another. Another of today's framing questions is, what are the most effective local, national, and global actions to put gender and social equity at the heart of a sustainable health future? I would argue that any sustainable development strategy must rest on a foundation of gender equality and human rights for all. And this includes health policies, programs, and services that are guided by the principles of things like survivor-centered care, a rights-based approach, having them be trauma-informed, gender-affirming, and inclusive of all gender diversity. It should ensure that services are accessible, acceptable, and appropriate for the people that they serve, and are rooted in community-led approaches and solutions. Accountability is also crucial, particularly for the most vulnerable who are living in our communities. And that includes children and youth, survivors of violence, our LGBTQI+ brothers and sisters, and people living with HIV. Sustainable health for all should be informed by strategies and guidance and policies that plan and fund and deliver health services. These include policies to end stigma and discrimination and violence, to codify gender equality and human rights for all, and provide adequate and stable funding. A policy is only a policy on paper if it doesn't have the funding and the resources to back it up and to implement it. It's also important to be thinking about our workforces, the people who are designing and delivering the services that improve health and well-being for all. It's important that our workforces are diverse, are equitable, are appropriately compensated, that they have the technical skills, and are also provided with quality mental health and psychosocial support services. Such a workforce is much better able to deliver these approaches, these services to advance the health of women and gender and sexual minorities, their leadership opportunities, to provide safe work environments with fair remuneration and non-discrimination. And it's a workforce that's better equipped to identify and manage vicarious trauma, compassion fatigue, and burnout amongst healthcare providers, which is something that I repeatedly saw throughout my work. And finally, we must continue to utilize and collect sex and age disaggregated data and evidence to inform our policy planning and service delivery. Finally, I've come to the third and final theme that I wanted to highlight today, and that is that transforming the world into one where health equity and social justice is realized means embracing feminist principles and living them out in our daily lives. This means, amongst other things, challenging these structural inequalities of patriarchy and homophobia and transphobia and racism in order to create a just and sustainable world and communities where we can all live lives free of violence and inequality. It means lifting up the voices of people who have been marginalized and made vulnerable or otherwise rendered invisible. As the wonderful author Arundhati Roy has said, there's really no such thing as the voiceless. There are only the deliberately silenced or the preferably unheard. Social change is rooted in community. Policy is important. Programs and services are important. But sustained change comes from individuals, families, households, and communities. To realize that change that we want to see in the world, we must continue to foster these safe spaces for people to engage in dialogue, particularly around really difficult conversations like gender identity, social and cultural norms, and the normalization of violence. Solidarity and the work of social, economic, and environmental justice has never been as urgent and essential as it is today. Support each other, amplify each other's voices, and reject the stigma and the discrimination and violence that divides us and wherever it appears. And remember, every single person who is here today is a leader. Don't look to politicians to solve our problems, because you're only going to be disappointed. We all have the knowledge and the skills and the dedication to build a more just and sustainable world if we work in partnership and solidarity together. So I want to end by saying a big thank you once again to the organizers of this convening for inviting me to speak today. And I look forward to being in discussion and dialogue with you all. So thank you so much.
Thank you very much, Ms. Amelia. Thank you very, very much for that wonderful speech that you gave us. I think taking from what you're saying, it's evident that advancing gender equity, social inclusion, and well-being through integrated health approaches requires a multifaceted strategy. And I really like how you're saying that we must be able to create safe spaces where we allow people to talk about these sensitive issues. And this is one platform, EarthHug, where we get to converse with the global world to talk about these issues. So thank you very much. And I hope to hear more as we get into the second session. But before we do that, I'm going to ask Dr. Mutero. I hope you have been fiddling with your instrument and you can just serenade us a little bit. Over to you just for a few minutes, Dr. Mutero.
So I tried to fiddle with the settings. I hope that it's going to work this time around.
It will work.
Can you hear anything?
Yes, we can.
So again, I'll reintroduce the instrument because it's important that we know it. This is Mbira. Of course, it's played there. I'm trying to hide the background. The Mbira is originally from Zimbabwe, from Mozambique actually, but it was brought to Zimbabwe by some man called Jeke Tapera. We then added some keys to make it Zimbabwean. Now I teach it in South Africa. So it's essentially an African instrument. So colleagues who are not in Africa, welcome to Africa.
You disappeared again.
Sound is gone.
Gone.
It's gone, but okay. It's gone. I think maybe you are too close or something, because when you are relaxed, we can hear it. Nothing.
I think the same people who are trying to reverse any gains that we've made around gender equity are doing the same to my music. So for now, let's speak the gender issues.
Okay.
As I try to fix
Well,
it.
we will not give up. I will keep trying until we get it. So this time, let me just thank everyone who participated in session 1. And we are giving way to session 2, where we are now going to the panel discussion with different speakers. And this session will be moderated by my colleague, Dr. Tinashe Mutero. So I'm going to give you the floor. Over to you, sir.
Thank you very much, Dr. Halase. So colleagues, we meet again now, not as an artist, but my role now is to try to have a beautiful conversation going forward. But I think the tone has already been set by Amelia, if I may. She's already spoken about how we missed an opportunity after COVID-19 to go to normalcy. And we continued to live in ways, in fact, we have made it worse to live in ways that are not beneficial to anyone. So I sincerely hope that, in this session, we will hear from different voices on how we can, improve the ways that we relate with amongst ourselves as human beings, but also with the environment for improved well-being and improved health outcomes. My duty here, ladies and gentlemen, is quite easy. We have a good panel that has been working in this space, trying to push boundaries trying to make sure that, as Amelia has spoken about, that, we live the feminist principles in, every day. But of course, these are difficult tasks that we hope to hear from them, how they've managed to do it. And we've got 4 panelists. I'm going to briefly introduce them, fully knowing that their profiles, the work that they've done. It's quite a lot to even speak in this space, but I hope that with my brief introductions, I'm going to do enough to, to want you to want to engage with them after the session. So we have Dr. Ayobami Adekola. He is a public health researcher at the University of South Africa, who specializes in leveraging technology to improve health literacy and sexual health and reproductive health care access in underserved communities. His expertise is in qualitative modeling and policy analysis, and he does this to address health inequities and determinants. His research has been studied globally, and it has been incorporated into policies by government departments, private institutions, contributing to sustainable development goals. Dr. Ayobami Adekola also serves as the on the editorial board of Research International Journal of Qualitative Methods and PLOS One. We also have in our midst Dr. Bridget. She's an anthropologist specializing in development, ecology, communication, sexuality, health, One Health, and nutrition with a gender lens. Since 1993, she has worked and I should say in 1993, I was in grade 1, and now my son is in grade 1. She has worked as an independent consultant, spending 30 years in Southern Africa. She has collaborated with national and international agencies across Africa and Asia, providing training, designing and evaluating projects, and conducting research as well. So essentially, she's been part of Southern Africa. She's been part of the process that has made change to Southern Africa. Currently, her focus is on gender, emerging infectious diseases, and climate change from a One Health perspective. She has conducted gender analysis and developed gender strategies for grassroots projects and ministries in agriculture, education, and health. We also have amongst us Irene Mutambo. Irene is a PhD graduate fellow at International Livestock Research Institute in Nairobi. She's currently pursuing a PhD in Gender and Development Studies from the University of Nairobi's Department of Anthropology, Gender and African Studies. Irene's research focuses on gender dynamics in gender equity and social inclusion. Prior to a PhD, she worked as a consultant at ILRI, which is the International Livestock Research Institute, for over 5 years, conducting gender research on empowerment, food and nutrition security, food safety in informal markets, and the adoption of agricultural technologies in innovations within the smallholder pig value chain development project in Uganda and Kenya. She is the holder of a master's in gender studies and a BA in social sciences from Makerere University in Uganda. And lastly, on our panel, we've got Dr. Benson Mutuku, who works at CABI, where he ensures that gender is integrated across projects and programs. He collaborates with staff to incorporate gender-responsive and transformative approaches into proposal design, implementation, monitoring, and reporting. Dr. Mutuku leads gender-responsive programming, aligning with global best practices, donor requirements, and gender equality policy. Yeah, he's got over 17 years experience where he has worked within international NGOs, and the private sector and government, focusing on gender and nutrition programs in agriculture, food systems, financial inclusion, policy, education, and health. And he has been part of multi-country projects in Africa, South America, and Asia, funded by organizations including FAO, IFAD, the EU, the USAID. So colleagues, I think you can get a sense that the panel that we have is got broad experiences. and they're going obviously speak from their perspective, from the communities, from the organizations that they've worked with, and of course from their lives. But to guide us into this conversation, to the panelists, we've already heard from Amelia that progress should happen, and progress should happen now. We want us to think of the presentation that has been given, and of course, thoughts that have been lingering within you over the days, to help us understand or speak to answering how gender and social equity shape health outcomes, especially in marginalized communities. We know that there's work that we've been doing, but we want, with concrete examples of how we've been working, to speak to how gender and social equity is helping to shape health outcomes, especially in marginalized communities. But we are aware, and I'll get back to the keynote speaker, that there are structural systemic challenges that we are seeing now that we've not seen any time before today, when politics is going somewhere. So we are aware that there are big obstacles that we are facing in our communities. Please share with us some of these obstacles that you are facing in your work, but of course, the ways that you have used to overcome some of them. And to get us into this discussion, I'm going to invite Dr. Bridget to first respond to this. Dr. Bridget, how do gender and social equity shape health outcomes, especially in marginalized communities? And also, secondly, what are the biggest obstacles to gender and social equity of healthcare within these communities, and how can we navigate through these challenges? I also invite Irene to this conversation, particularly Dr. Bridget.
Thank you very much. Thank you very much for inviting me to participate in this discussion. Thank you for this question. It's a huge question indeed, because it encompasses all aspects of life, all aspects of social life. It relates to agriculture, it relates to education, it relates to justice. You know, gender, everything is gendered. Animals are gendered. Plants are gendered. Access to those plants, access to animals, access to services are gendered. So it's very important for us to start from the beginning. What is gender? I think that Dr. Amelia explained it to us, but maybe we need to come back to it. Gender is a social concept, and it's a relation between men and women and people who feel differently. And it's a relation of power. Why do we say that it's a relation of power? It's a relation of power because as we do things differently, our society, why? Because society considers us differently, consider differently a man, an old man, a young man, a young girl, elderly women. They consider those persons differently, and they attribute different role. And the access to the resources of different people are also different. So because of this reason, because of this situation, people will encounter different risks in their daily activity. They will face those reality with different instruments, with different knowledge, with different tools. And this will affect not only the possibility to get the disease, but the possibility to respond to the disease. And this will be true for human disease, but it will be true also for plant disease. It will be true for animal disease. So the way we are educated, the way we are socialized, influence all the capacity that one person has, okay? And it's depend on where we are born, the place where we live, if we are in urban area, rural area, it will depend on the class. It will depend on the rank of birth, if we have the first son, the second son, the rank of marriage, if we have the first wife, the second wife. It will depend also on our age, as I mentioned earlier. So all those elements will affect or will impact our power relation with each other. And this will impact the capacity, the possibilities that we have to understand disease, to respond to the disease. Not only if we are personally affected, but if other person in our surrounding are affected. So if a person is marginalized, if a person has less access to education, if a person has less access to health services, if the health services are not designed adequately for us, we will be in a situation of impossibility to get the right information, to get the right resource to deal with the situation. So not only us as individuals, we are shaped by society, we are shaped by our culture, but also the institution around us, the legal system, the education system, the judicial system, all system around us. That's why I said everything is gendered. All those systems are shaped by those unequal gender relationship. So when we say that health is not friendly with certain group of person. By example, if we think about young person, often young person do not feel comfortable to go to the health center because health center are not friendly with them. Health center are often also not friendly toward men. Men do not feel comfortable going to the health center. They feel that it's a place where mainly women are going, where mainly children are going. So all those institutions are shaped by the social norm, are shaped by those power relation between men and women, and are more or less adapted, are more or less friendly to receiving men and women, people from different sexual orientation, people from different age, people from different gender. So it's why we say that gender will shape the risk to get disease, the possibility to prevent disease, and the way we are going to respond to the situation. So basically, it's what I can say at the moment. I don't know. I think that we can have maybe Irene or somebody else to contribute, and then we will go to the obstacle. But just to give the situation about how gender shape our access to health and the risk and the duration of disease, the possibility of people to treat them and to respond to health situation. Over to you.
Okay, thank you, Bridget. Just to add on, one of the issues that we can also highlight is the economic constraint. In this aspect, we look at financial limitation as being one of the major hindrance or that can shape health outcomes. And I'll tailor my discussion from a pastoralist community that I've been working in for the last 3 years. You find that access to resource and ownership of resource really influence the health outcome of men, women, children within the household or within the community. So because if an individual does not have access to health, to financial muscle, or they do not have income to access these healthcare services, they cannot really attend health service in time. And this also can affect their lives and life of the children. And I'll give an example of a pastoral community where I'm working on the disease, which is called Rift Valley fever. And this is a disease that is transmitted between livestock and human. And if a woman or a child or a man does not have money to go and access health in time, the community and the household within where they live are able, in fact, in a risk exposure, or they are prone to getting RVF, which later affect their livelihood because they depend on milk and meat as a source of food. And this increases their risk to getting the disease. But also I want to bring in the aspect of culture and traditional norms that govern these communities, especially within the pastoral communities. We find that male dominance is really rampant. And because of these traditional roles or traditional power that is given to a man, if a woman fell sick within the household, or even if a child fell sick, and these are the reports that we got from the field, you really have to call your husband, let this person know that your child or myself, I'm not feeling well and I need to go to the hospital. So not until the husband is able to give a green light to the wife to take the child to the hospital or to go by herself, then she cannot go. So traditional rules, traditional norms, the attitude and values that govern our communities also influence the health outcome. Who gets the service first? Which hospital are you even going to? Is it a public? Is it a private hospital? So I also want to talk about the roles and responsibility within the household. You find out that different roles are assigned to different groups of people. It could be either children, it could be either men, but I mean, because of the different roles and because of lack of knowledge or access to information, RVF can easily or shall continue to be transmitted from one household to the other, just because of the roles and the responsibilities, but also due to access of information, because someone now then cannot protect themselves against the disease, and this increases their vulnerability to the disease. So maybe we can go to the next question, and in the next question we are discussing about what are some of the biggest obstacles that affect gender and social outcome between men and women. And as I earlier mentioned, I'll just build on what I have just spoken, that gender-based disparities in livestock ownership, decision-making, and power. This is very predominant in pastoralist communities, whereby I were given a story from one of the focus group discussion, that when a woman is getting married, the parents tend to give them a cow. But once they get into their homes now, where they are staying with a husband and a wife, then the man takes over this cow or the goat that she has been given. So now you see how this plays out, that even if she has an ownership, she doesn't really have the decision power. She does not have the decision power. She does not have control on when to sell the cow, to sell the goat, to go to the hospital. And this really translates into the vulnerability of a woman, the vulnerability of the children in the household, because they do not have this power to sell whatever they have that they can use or they can rely on to go and seek health services. But also they don't have access to the market. They cannot stand or they cannot carry the cow or the goat and take it to the market and sell, given that it is a Muslim culture, a Muslim community. you have really to rely either on your husband to sell for you, or you have to rely on the hope of your elder son within the community or within the household. And if you do not have the son to help you do that, then you cannot access health services. I'll also talk about limited access to resources and healthcare. And we found out that in these communities, healthcare services are really far. Someone has to move over 5 kilometers before you reach to a health center. And if you are sick, I wouldn't imagine that you'd have the energy to move for those 5 kilometers to look for a health services, because they are really in rural areas that even the transport systems are really down, very hard to reach. So you find that these are some of the obstacles that can really influence the health outcome of our communities that you are working in. I'll let Bridget pick up from there. Thank you.
Thank you, Irene. Thank you. Yes, of course, I can pick up from. When I work on the obstacle, I think at different level. I think at the individual level, the household level, the community level, you know, the institution level, and then the national level. So I will try to explain a little bit the way I see it. At the individual level, as I spoke earlier about the education, the socialization of the individual, often women are put in a second place. They are second order human being, you know. They are not entitled to the same right, to the same role, the power decision in society, in community, in their institution. So they start feeling unable to take responsibility, to assume certain role. So at the individual level, there is a lack, what we call empowerment, okay? So this work at individual level need to be done. And often we do this by mentoring, by training on empowerment, empowering people, empowering a marginalized group, empowering young girls, empowering people who have a specific disease so they can speak out, so they can organize themselves. So this is the individual level. Then there is a household level, because as Irene mentioned, the decision power within the household is very hierarchical, and often women cannot take decision to go to the health center for their own disease, or to take their children, or to take their animal, to take an animal, to call the veterinary to treat a goat, to treat a chicken. So at this level, it's also necessary to do work, sensitization, so that the woman that is trying to empower herself is supported by her household, by her network, and by the community. So in addition to this work at household level, it's necessary to do a work of sensitization at community level. If you want to empower women to be, to raise a chicken, to raise a goat, and to have more knowledge, often it's necessary to work with her community, with their community, so that they allow women to participate in training, to be vaccinated, to be community agent, and to look around the community, to deal with animals. And the community need to accept, the community need to understand that it's important for the women to do that. So this level also is important. So individual level, household level, community level. And then for me, I see the institutional level. For example, I was speaking about the Ministry of Health, the Ministry of Agriculture, all those institutions, even the institution of the NGO, because often we see that the institutional culture of those structure or those institutions are not gender sensitive, they are not gender transformative. They don't do a gender analysis. They don't look at themselves. They don't look at their own practice. They don't look at their own attitude. And as I was mentioning in relation to the health center, they are not friendly with young people. They are not friendly with men. And we will see often, by example, in the Ministry of Agriculture as well. We have a structure with essentially in most countries, masculine with extension agent who are often men, and in many cultures there is a difficulty for men to speak with women in the villages, you know. So this culture, this difficulty to work with women is also is part of the cultural the culture of the institution and need to be addressed. Often those institutions, those organizations do not have a policy in relation to harassment, do not have a gender strategy. So they are not empowered, they are not looking and transforming the relation between men and women and looking at their attitude toward other kind of gender minority or people with a different sexual orientation. And at the overall level, for me, an obstacle, it's at national level, because once again, it's about policy. When we see the policy and in terms of access to land, access to education in many countries in Southern Africa, we see that younger have less access to education than their male colleague. So this is a problem.
Jag kikade om du var här, men jag tänkte också jag ska hem och Ayla hem.
So when we look at the obstacle and we want to transform the situation and we develop project aiming at transforming gender relation, we need to look at those different levels and have a specific intervention, specific sensitization, specific activity to try to deal with all those different levels. Even if we want something which is quite simple, you know, we say we want to empower women, but women are not going to be empowered on their own. They cannot be empowered alone. They need to find an environment that is conducive for their empowerment. Thank you. Over to you.
Thank you. Thank you very much, Doc. I get the sense, colleagues, that we faced with the problem, one that needs to be tackled from now, you know, as a person. But Dr. Yobani indulged me here that at a personal level, as men, as women who are in power, I want to believe that most people who are in this space are privileged in one way or the other. How do we make sure that we are aware of our own privileges and that we change that in a way that, again, Dr. Emily has spoken about, that we need to make sure that we live the feminist principles. So we have privileges that some we are aware of, some that perpetuate gender inequalities. What can we do as individuals, right? That's number one. But we've also been told that the challenges and even the solutions are in different spaces from the individual to the upper systems. We know currently that in the United States that there are two genders, male or female. And that has its own challenges from what has been said so far, that is going to worsen the inequalities. What do we do faced with such challenges that come from people with money, but also from men like you and me? I'll start with you, Dr. Yobani. But of course, we can also respond to everything that has been said by the speakers.
Yeah, thanks so much, Dr. Mutero. I need to congratulate the two speakers. They actually did justice to those two questions. And going back to the question which you asked, I think the lack of self-awareness or denialism is real. And I have to explain myself what am I doing with my degree in gender and sexuality studies? Because, okay, I study a degree in public health, and people, even highly educated people, sometimes professors, ask, what are you doing in that department? They do not think it is relevant to talk about gender. And that, like you said, is a big problem, because if we have that lack of understanding at that level with people who are highly educated or who can influence policies, then we need to know that the work is enormous. It's daunting, but we don't have to give up. One, I think what fitted in is the patriarchal background that we have, or prevailing in Africa, and I don't think it's limited to Africa anyway. But one thing that is important that we can do, personally as a researcher, is to make sure that try to make available intersectional data that hides disparities, because you do not argue with facts. When we conduct research, when we intensify our efforts and advocacy too, try to show evidence on how gender is a critical determinant of health. So you cannot deny, even if you are going to deny it, the statistic will be so obvious that you can see. And I think that is one thing that is lacking, especially at grassroots level. People do not prioritize collecting intersectional data that shows how class, race, gender, how all these affect the access to, how it determines access and quality and the outcome of healthcare services that people receive. One of the examples I want to give is one kind of gender-based violence that has been normalized. In Africa, we don't even talk about it. One of it is obstetric violence. Now, we don't see people reporting or talking about that, where a woman who wants to access, during childbirth, who wants to access reproductive healthcare services, they face mistreatment and abuse and disrespect from health facilities. And people are trained, they collect salaries, they go there every day, they dress up in a nice white uniform, but you are abusing people who want to access health services. And the women too, they do not see anything wrong, because everybody expects that during childbirth, one nurse is either heckling you or saying some things to you, and we think we normalize that. In any case, you have also, I think one of the speakers alluded to that, where we have members of LGBT communities who do not want to go to the hospitals because the operation is completely heteronormative. So it's a kind of hostility that they're going to face when they move to that hospital to access services. So they feel like they rather stay away. And all of this, in a way, are things that we need to talk about. So how do we address this as men? I think, like I said, one is to make scientific, accurate fact available, and two, to intensify our advocacy efforts to make sure that we do not keep silent about it, to address and for me, every time I have to face or speak to people who are some kind like challenging, what is big deal about gender? Are you trying to make us a member of LGBTQ now? Are you asking us? And again, another thing is religion. Okay, so I think one of the programs that I'm involved with
Team. Have we lost the speaker, or if New is lost now?
I think we lost him.
If you discriminate, that is gender-based violence. So we try to conscientize and mobilize them so that there could be a kind of transformative movement within the faith society, because religion has been one of the key factors that, perpetuate, gender-based violence. And this feature in also that doctor you meet at the hospital, the nurses, the healthcare workers, they go to one church or the other. So without mentioning denomination, some faith, because of their belief, they don't believe in contraceptive. And so when a patient approach, go to a clinic or a facility to require a kind of contraceptive services, you start suggesting or prescribing alternative like do not kill an unborn child, you are a murderer, and things like that. You now compromising your professional obligation because of your religion. So, and a whole lot of these things happen. And what we need to do is to make sure that we make available, we generate scientifically accurate data, break it down, communicate it at grassroots level in the language in which people can relate with, they can understand. And with literacy, with education and empowerment, I think we will get there. This is a systemic thing, and I want to make that last statement. To ensure equity, it requires systemic change. It's not something we can do comically. It's not just a goodwill message, but it has to be an enforced collaborative action. I think I will stop there for now. Thank you.
Thank you, Doc. I want to pick up from where you are and perhaps also invite Dr. Mtuku to respond, also tying through what has been said by the previous speakers. I love the fact that you speak about using science, and I think Dr. Mtuku is placed in a good position to speak on how they are using science, of course, at CABI, you know, to enforce change. But there's another issue that you spoke about, which is on mobilizing for organizing. And I think one of the challenges that the community that Dr. Irene works in faces is essentially a problem of failing to organize for action, which is the problem of, you know, where women's agents is left on men, that men should say you should go to the hospital or not. So to Dr. Mtuku, my questions are two. In spaces where we have, like the one that Erin has been working in, how do we organize? Of course, mobilizing is one thing. How do we organize to have concrete action? There's a noise somewhere. How do we organize in local communities to fight to get the actions that bring change in local communities? That's at the local level. But we've already heard from Dr. Ayubami that there's need to use science for, you know, to improve health outcomes. And we're in a space where you're working with communities, you're working with science, you're working with how have you been doing this, and what else can we do? What are the gaps that we as researchers can you know, help solve?
Sure. Thank you, Tinashe, and thank you all. It's a great pleasure meeting you. And I think it's a good opportunity speaking after the other speakers, because I get an opportunity to add one or two things as I respond to the questions that you've been able to raise. And let me say there is one thing that we can't really forget when we are discussing about matters pertaining gender. And these are the levels of socialization. These institutions help us in terms of understanding on how we are going to shape our programs and how we are going to customize. Look at the family, where we have both men and women, where children learn so many things on how to do quite a number of things. Look at the faith-based institutions, the community, and also what we call the schools. So they play a key role on how we are able to respond to quite a number of issues, as well as nowadays, currently, what we are calling social media that is shaping quite a lot. And so if you look at the levels of socialization, they even bring us to that connotation of how can we have access to and how can we control. The participation component, who participates on what and who does what. And if you look at, for instance, any community gathering, you realize that there are those who participate materially, those who participate by decision making, and those who actually are represented in terms of decision making or participating. So these are learned within the agents or the institutions of socialization. And therefore, this brings in the question of now, how do we look at the gender and power relations? Because then the social cultural attributes would really lead to the attitudes, the stereotypes, as well as the practices. And with these kind of institutions, we have the roles where we do have the reproductive, productive, and community roles. In a healthcare kind of a setup, we do have, let's look like for antenatal care, where a majority of these roles are given to women. When it comes to delivery, the woman is left, and postnatal is also left to the woman to take care of all this. So how can we look at this kind of triple burden or the care role that would really help in terms of all this? And therefore, trying to respond to really how we could organize some of these concrete actions at local level. One of the things that we could do is utilize the models and approaches, because if you want to change the issues, the norms, the social cultural, the attitudes, you have to design a community or a local-led solution that is going to help people to start demystifying what they have grown knowing. Because if you have to sensitize, or if you have to change the way people think or believe, then there is an action that needs to come in. And this is now coming up with a model or an approach. An example of a model, there is a model that is called the social action and analysis model. And this helps in terms of looking at the beliefs, the norms, and how the community or the institutions could really look on how to address that. The community scorecard, which has been used a lot actually for most of the health interventions, because you bring the communities and you make sure men sit separately, women separately, identify the issues that are affecting them when it comes to healthcare. Within that, they are able to prioritize. They do a scoring. And then towards the end, there is the interface that brings an action plan, a community-led initiative that helps the communities to start understanding how to do this. The third area that I'll talk about is about where we have gone. And when it comes to scientific components, we've ran away from gender and power analysis. And gender and power analysis helps us a lot to look at the opportunities, the priorities, what are the needs of men, what are the needs of women, as we design these programs for us to design approaches that are going to reach to each and every person within the right dimension. And so it is up to us to always keep on asking ourselves, as we write proposals, as we develop interventions, are we looking at the power imbalances? Are we looking at the social cultural issues that are affecting men and women? I would also talk about the gender responsive budgeting, which is quite a key area for us to really look at. Because if we don't involve the men and women in terms of participating, then we end up coming up with budgets that are asymmetrical. And once you roll this down to implementation, you realize that a majority of the budgets go into the hands of men, and we leave women out of this. And therefore, that also contributes to matters of participating. I was looking at a program that we are working across Africa, and I was really looking at how we do some discriminations without knowing, especially when we organize meetings in very big hotels where people have to spend for 5 days. What does this mean? It means majority of the attendees will be men, and most women will not be allowed to come and spend for 5 days, given that they have the care roles. They have, you know, a number of things that the men feel insecure that she has gone for 5 days and she's not be able to do the care roles. And so we have to look at how we design those kind of initiatives to ensure that the participation of both works really well. I will also talk about where we are lacking a lot in terms of our researches, disaggregation of data in terms of sex, gender, and also age. This is quite important because what would affect a person between the age of 18 and 25 is not what would affect a person who is at the age of 40 to 45. And that would really help us. Looking at the sex disaggregation and also the gendered kind of a disaggregation. Yes, we had 50 women and 50 men attending a meeting. So what came out of the meeting from the discussions from women and men? What can we do to ensure that participation and kind of involvement takes place in the right way? Looking at also The prevention of sexual exploitation and abuse, especially in healthcare interventions, is quite important. It has been discussed. I will not overemphasize. And so to wrap up this, I would be able to say it's upon us to look at how we can have interventions that would build the agency. And the agency looks at the self-esteem. It looks at the confidence, the matters that are pertaining, how the structures that we have talked about can be changed. And also the voice. How can we amplify the voice of women for them to participate and make decisions in the forums that we do organize? And finally, the structure. And to wrap up this also, male engagement is also quite critical in the interventions that we do work. We have seen where violence has been really deepened when we leave men also in terms of when they are designing programs. So Tinashe, I would be able to really mention about that in regards to the actions at the local level, as well as how to bring science and research into action in the work that we do. Back to you, Tinashe.
Thank you very much, Doc. I think everyone here in this space will agree that there was a lot to learn from what you just said. Of course, both of you, Dr. Yubami. I want in this stage to just assume the role of the previous females that spoke. And I do that fully knowing that I might be abusing privilege here and speaking unlike them. It appears to me, at least, that there's a lot of goodness that we know. There's a lot of goodness, good structures that we have, but the problem persists. And I want to take us back to what our keynote speaker, Dr. Amelia, spoke about, living the feminist principles, having them into action in our everyday. I'm an avid consumer of podcasts. In one of the podcasts that I watched, they now talk about feminazi in ways to try to silence feminists. So I'll take to the women. After hearing what we have heard so far, our keynote speaker, Dr. Amelia, where do you think, if anywhere, we are failing to get back to live a world where the feminist principles are part of our everyday life? But perhaps, does this space understand what feminist principles are? We could use this opportunity to just speak to us about the feminist principles in relation to the challenges that have been spoken about by all the panelists, and for the solution that we've spoken about. And this is open again to Irene and Dr. Bridget. I've put aside the men, but just hear from you what feminist principles are, and are we living that?
Thank you for this question. Very interesting. You shouldn't leave the men away from this conversation, you know. We need to go back to this definition. What is it to be feminist? And we should all be feminist, because feminism is about fighting for equality. So potentially, I hope that all people who work on gender issue should consider and are considering themselves as feminist. There is nothing wrong about being willing to be equal and work on equal foot and access to the same resources and access to the same position. This is what it is to be feminist, to fight against inequalities between men and women, and also between other type of group of people. So yes, I am a feminist. And you are asking what are the principles? I just depend in which, in terms of research, by example, feminist principle is to develop an horizontal power relation. So authority and power relation are not vertical, they are horizontal. I mean, this is a feminist principle that we use in feminist organization. Giving voice to women using methodologies that are participatory, that engage women to develop their own theory, their own view on society, that are emic, coming from the local context. Those are feminist principles, you know, and as our last colleague was mentioning, you know, giving voice to women is part of all the principles that we are adopting for research, and also doing a gender analysis. Identifying, as we were discussing in this panel, we're identifying the problem, identifying the obstacle, identifying the solution. A feminist analysis, feminist action research will not only focus on the analysis of the situation, but would try with the participants, the male and the female participant, to find solution and to work on the solution together. So in research is what I consider a feminist approach and for feminist basis for our work. I hope I didn't forget something. Maybe my colleague Irene can help us with that also. Thank you.
Thank you, Bridget, and thank you, Tinashe. From my understanding, feminist principles, to me, they are more like those principles that challenge power dynamics within the community, right? So what are those power dynamics? What are those more like socialized or the norm that is in the community? I mean, it hurts though, but it is those unwritten rules within the community. And these unwritten rules really challenge power dynamics. And this is more visible when you look at the decision-making in most of the aspects that happen within the community or within the household. So if we are able to challenge the power dynamics, if we are able to promote inclusion and diversity, these are some of the issues that feminist principles look at, because they are looking at gender and development. We are not looking at women in development. We are looking at gender in development, trying to ensure that we bring each and every person on board. And if we are able to bring each person on board and addressing the issue of equity, I mean, we are not only looking at equality, but we are looking at equity in each aspect. How are we able to engage each individual, the children, the elder, the women, the men? I'm writing a paper on exposure risk to RVF in children, and this is the area that has been underlooked. And these children are vulnerable also to RVF, according to what I'm writing anyway. But if we are not promoting inclusion, if we are not promoting diversity to ensure that each person is included in health, to ensure that we have an equitable, sustainable outcome, then I think we are not doing the right job. Another issue that feminist principle that tries to look at is the issue of prioritizing the care and the well-being of everyone. I'll give an example of in a pastoral community where we went for focus group discussion, and then we met with women from female-headed households. They are either divorced or they lost their husbands, and it was their time for them to be called for a discussion group. And they were so happy. And I mean, they were wondering why would we even thought about them, because they told us, we have never been in such groups. So if you do not prioritize their well-being, if you do not prioritize their inclusion in the programs, in interventions that are trying to address the issues of Rift Valley fever exposure, then you're leaving out a lot of things. So for me, I would imagine that for us to have a sustainable future with equal access to resources, with equal access to the healthcare services, with equal access to ownership and to access to resources and all these other things, the power dynamics within the household, the power relations, we need to ensure that we bring everyone on board. Thank you. Over to you, Tinyashi.
Thank you very much. This is safe to say that from what we heard from Professor Chimbari when he opened up that the Eco Health International or the principles of Eco Health are not to leave anyone behind. I get the sense that Eco Health International itself is a feminist organization in the work that they do to improve health outcomes. It might not be somewhere on paper there, but in practice, and of course, by the work that we've also done in different countries with Prof. Chimbari, Prof. Dr. Kalinda, what we've just heard that the work that we do in communities should be participatory, should have horizontal power dynamics, and allow silenced voices and unusual voices to be heard. I think speaks to the core of what Eco Health International as an organization does. But ladies and gentlemen, I think at this stage, we want to turn our conversation a bit to Dr. Ayobami. So we need to speak a bit about how we can embed gender equity into policies and community engagement. And Dr. Ayobami, together with Dr. Benson Mtuku, please indulge us into answering the question, how can governments, business, civil society work together to embed gender equality into long-term health policies? That's number one. Number two, why is community engagement crucial for inclusive health and social equity? And how can we ensure it is truly participatory? And I underline truly participatory. We've got the tendency of thinking that some of the work that we do is participatory. While it is not, it takes a lot of courage to just evaluate ourselves in terms of how participatory our work is. And how do we do that? And also, how do we make sure that governments include these issues that we're speaking to into policies? Dr. Ayobami, start with you.
Yeah, thank you very much. Yeah, the question is, how can governments, businesses, and civil society work together to embed gender equity into long-term health policies? Well, for me, I think collaboration is key, because there have to be a kind of an alignment around and a shared vision that's where people can co-develop with these three sectors, the government, the business, and civil society. The three sectors have to co-develop gender-responsive policies and invest in data systems that track equity indicators, because you need to make data-driven decisions to be able to get to make it effective. One, I would say governments must lead with inclusive policy frameworks, which means governments have to show that leadership with intention not to leave anybody behind, whether they are women, marginalized group, or people in rural area, or whether they are men too. Businesses can fund and support gender-sensitive health programs and also develop workplace policies, like it has been mentioned by the speakers earlier. Civil society must hold all stakeholders accountable and amplify community voices. Of course, civil society within their own organization must have that self-awareness, as it has been highlighted earlier too, that they need to be aware and also have this policy working within them. So I believe actually that multi-sectorial partnership can drive sustainable policy reform and fund, and of course also funding allocation that could be for long-term health policy. Let me break this down. So when I talk about data-driven policies, we talking about collecting and analyzing sex disaggregated data. This is to identify gaps so that an intervention can be tailored. This data will inform the kind of intervention that needs to be done. And of course, inclusive design of policy. We have to co-create policy with women, LGBTQ communities, and marginalized groups to address diverse needs. More often than not, we see people sitting in the office, in the fancy offices they have, and they come up with solutions to a problem. And then they take it to the community and say, this is what you need. We know your problem. This is how we're going to solve it. It doesn't work that way. We need to hear from people. How do they want the problem to be solved? And they have to be involved in the designing of the policy, in the designing of the programs for it to be effective. And I think other speakers have also mentioned that. So when we talk about community engagement or collaboration, it's just go beyond tokenism. Just say, okay, I've spoken to you. It means active engagement where feedback can be processed and be incorporated into the decision making, and people who are going to be at the bottom end of that decision are going to be part of the decision, and there should be a transparent feedback where they know that their input has been incorporated, their input has been processed and has been incorporated. Of course, then there's funding and accountability. Governments and businesses should allocate dedicated budgets, while civil society should monitor the implementation. Of course, there should be monitoring and evaluation, and of course, an auditing process to make sure that the resources that has been allocated are judiciously used and they actually address what it's meant to do. It has also been mentioned that sometimes you allocate resources to address issues that affect women, and it ended up being with men. And so these are the things that can be looked at. Of course, then workplace and community integration, businesses can adopt equitable health benefits, and civil society can lead grassroots awareness campaign. And the idea is to make everybody, even the women, the people in underserved communities, members of marginalized community, to become advocates. They need to become part of the solution. They need to be integrated into the whole process, so that this is how you can have a sustainable health policies. And of course, there have to be education and training, where the policymakers themselves are trained on their gender biases, and of course the healthcare providers. We've spoken about people working to the hospitals and healthcare facilities, and they are being treated with disrespect, or they have a kind of hostile services or judgmental services or non-friendly services. This can be addressed by giving culturally competent training, where people become aware that when government make budgets for citizens, government does not make budget for straight people or for heteronormative people. Government make budget for everybody. And if in a city of Tshwane, in Pretoria, the municipal make budgets for 3 million people. It does not say it's for black, white, women, men. It's for 3 million. And when you, as a civil servant, or as a doctor, as a nurse, as an officer, you walk into that facility, you are supposed to attend to everybody with the same attitude, with professionalism, with respect and dignity. And so this is what we talk about equity. So education and training is very important. So the key, I would say, is sustained partnership. So none of them should work in silos. Government, business, and civil society, they have to be a sustained partnership. We have to prioritize marginalized voices. Like the keynote speaker did mention that there people always have voices. It's either we refuse to listen to those voices, or we ignore them, or we suppress those voices. So we need to prioritize them, and we need to enforce accountability. There should be a mechanism to ensure Because when you talk about sustainable or long-term impact, there have to also be a kind of mechanism to make sure that you check what works and what does not work. That's through monitoring and evaluation. Back to you, Doc. Thank you.
Thank you. I'll quickly hand it over to Dr. Benson before I respond.
Sure. And thank you so much. And just to start off, it's to start by mentioning that we need some tailor-made interventions, because what we program for the government should not be the same approach that we are going to use for the private sector or for the CSOs. And I'll give an example of how I had an intervention that was developing policies. And the way I developed a policy for the private sector is not the same way I developed the policy for the government. Remember, we work towards governments, but then also private sector institutions are there to make profit. So how are you going to ensure that within that policy, they are able to still see the need for you to apply a gender policy? So that's one of the things that I think that we need to really look at in terms of looking at gender equality across the different institutions. Secondly, we need also to ensure that our policies and strategies have guidelines that can be followed to the latter. I have seen a majority of institutions or sectors developing guidelines and policies, but they are put in the shelf. Nobody looks at what needs to be done. And that is where we need to come up with the low-hanging fruits of what needs to be implemented as we develop these policies and these kind of guidelines. We need accountable actions. That's quite very critical, because if we don't hold these institutions accountable, then who is going to hold them? You give them resources. You get staff to work on different interventions. How can we ensure that we have the accountable actions put into place? And that is what Adekola said in terms of the monitoring and evaluation. That also involves a lot of gender audit and looking at what has been taken place, what has progressed and what has not. I would also talk about how we could also cascade the international, regional, and national frameworks. We do have frameworks that we all know, but a majority of the countries or institutions are not aware of this. We are, we had the meeting in, for the CSW happening. But my question would be, how are we ensuring that the different kind of frameworks that we align to are adhered, because adherence is quite key. And that's something that we have to really look at. And so looking at your second question in regards to the community engagements, I would start by saying that we need community-led participatory initiatives. We cannot run away from that. Designing a program at the national level, going to the local people for them to implement, we will continue missing the mark. We have to always engage these communities. Let's get their needs. I remember a time we had a program where we thought that women were going too far to take water from a river. And when we went and discussed and had a few discussions, we sank a borehole that was closer to the community. But at the end of the day, realized that the women were not still fetching water from this borehole. They still continued going to the river. So this really caught to us to attention. What can we do? We went back, conducted a gender analysis, and realized that actually women wanted that borehole in a different location. And we had now to look at those needs and drill another one. So we have to really look at what the community needs are for us to actually tailor-made the interventions. I know my colleagues have mentioned about dealing with social cultural issues and norms, but then there is need for more sensitization. If you get more education that is more formal without informalizing it, then at the end of the day, you end up having the theory. We need to have the practical. And the practical is what? What I can take to my home, what I can be able to go home, because change starts with me. And before I change others, I need to be transformed. And that's what we really need to look at to have successful community engagements and interventions. Back to you, Tinashe.
Thank you very much, gentlemen, for those insights. But it gets me to ask, of course, to both yourselves and our co-panelists, that when we do measure all this work that we are doing, we are measuring the importance of gender equity on health outcomes. As we put it now, it's simple to the ear, but on the ground, what are we looking at? What are we measuring? I hear that we should have gender disaggregated this and that, which is all okay, right? But let's get to, if we can, some of the specifics, that things that we, in the different capacities that we have, we're at different levels of learning to do this work. What are the things that we should be, alive to when we are gender budgeting, when we are doing an evaluation of whether our intervention is sort of moved the needle in terms of gender equity and improving health outcomes, particularly for improving health outcomes? What should we be on the lookout for? And here I hope that we are going to speak to all genders, not just women. But this is open to all the panelists, but we can start, of course, with Dr. Ayobami, who was spoke about these measurements.
Oh, thank you very much, Dr. Mutaro. I think there are key indicators for health outcomes that we need to, key metrics that we need to look out for. And one of it is mortality rate, especially you can look for maternal, infants. So you look at mortality rate, then you talk about also morbidity rate, or you can look at life expectancy, mental health status. These are all outcomes of health outcomes that are measurable within a particular population. You can look at the birth outcomes. You look at low birth weight and also the quality of life too. Then, of course, you also look at the health-related behaviors like the use of contraceptive, the use of, smoking rates, and all this. These are all health outcomes. So you also can talk about health literacy, which is another aspect, which also is mutually reinforcing when it comes to health outcomes, because the more people are health literate, the more they probably will do things that will lead to positive health outcomes. So, but basic metrics, you look at mortality rates, those are generic measurements: mortality rate, morbidity rate, life expectancy, mental health status, the birth outcomes, and quality of life. And I think there could be others that my colleagues may want to mention.
Indeed. I see. Thank you very much, Dr. I see Dr. Bridget already has a hand up to add.
Yes, thank you. I just wanted to add that, as my previous colleague said, it's important, all those indicators are important, but what we're struggling to is to disaggregate data. Disaggregate. Often all those data are available, but to get the data disaggregated by gender, by age group, by education, by place of residence is extremely difficult. I can give you data on rabies in Southern Africa, a paper we're writing with a colleague from OCHEA, where we identify that not the majority, but a huge proportion of young boys were bitten by dogs and get rabies. If you do not disaggregate the data by gender, if you don't disaggregate the data by age, if you don't disaggregate by residence, you don't see where is the problem. And in this case, the problem is in rural, gender is male, and age is young people, young boys. So disaggregating not only by gender, but by age and all those other determinant of health is extremely important for understanding the situation, any kind of situation. We saw it with COVID, when we start understanding that, and with HIV, that men were not going to be tested, and why men are not going to be tested. So we need to address the problem why men are not going to be tested. And men are dying more. Men are not doing the full treatment. You know, they are falling out of treatment. Why? And if you don't have those data disaggregated by all those different groups, we are missing the point. For me, this is a big call to, we need to get disaggregated data. Thank you.
Thank you, Doc. I think one cannot ever emphasize the need for that. Of course, we've seen a lot of questionnaires that have that section, but as we assume that the researchers don't know how to then use, right? But again, this space has allowed us to really take more care about the data that we use and how to then, that we collect, and how to then use it to inform decisions that help us across the different genders. Thank you for that helpful reminder. I see Dr. Benson, you've your hand up.
Sure. Some of the low-hanging tangible results that we should look for is one, transformed communities where men and women are sharing roles, because that's quite important, because we don't want to see antenatal care left to women. Would like to see also men contributing towards that. Would like also to see towards delivery, because this is a role for both that we need to see that taking into place. Decision-making, because it's quite key. And when we talk about the levels of decision-making, we want to see both men and women contributing and discussing, because the agency has been improved, the voice has been increased, and the right structures are put in place to ensure that everybody has that voice to contribute. I'm also looking at access and control. For instance, look at the nutritional components that we are talking about. And most of the land in Africa is owned by men. So how do we look at how women could have access and control towards this, so that they could also contribute towards the health outcomes in terms of the nutritional standards that are required within the households? I'm also looking at where we have communities that are free from gender-based violence, because once we agree on how we are going to work together, decisions will not lead to more violence. Decision will lead to more people working together and being able to contribute to a more common goal. And then I'm looking at access and control to resources and finances, where all of us would be able to be in a world where we could budget, we could sit down, agree, and see on how this can move forward. And then finally, it's about now the literacy levels. We need to see both formal and non-formal contributions, where because the agency has been strengthened, the trainings have been laid into that level where everybody feels that they have the education, they are empowered, then we see such kind of contributions within the different forums in the different areas that we are going to be in. So for me, I would look at those low-hanging fruits that would help us in terms of contributing towards the higher fruits that we are also looking at the higher levels. Thank you.
Thank you, Doc. I believe everyone here in this space has got a fruit that they can, clutch on to help us get to improve health outcomes. And so in the spirit of having everyone having an opportunity to speak, I'm going to invite my colleague, Dr. Kalinda, to facilitate a conversation with the floor. So that we interact with both our panelists and the keynote speaker.
Thank you, Dr. Mutero. Thank you for this wonderful conversation. And from this, I think we, both those of us who are listening in the background and the panelists, we've been able to pick up a couple of things. And I believe from those of us who are listening, we probably have contributions or questions to some of the important things that have been raised by our panelists. And this is the time that we can make a contribution to the conversation or raise a question or seek some clarifications on some of the things that have been raised. So if you please have a question, a comment, or you would like to make a contribution, kindly just ask your question or just raise your hand, and we will give you that opportunity to make your contribution, your question, or your comment. Yeah.
I will start with of course I had the opportunity to ask earlier, but I can again seize this one. We again, I'm going to get back to the major power that we have, political power that we have, which has taken a different stance. And we've heard, particularly from Dr. Ben, that we need to tailor-make interventions for governments. In the face of governments that seem to be hell-bent on going backwards, what kind of innovations can we have in this moment where it seems deliberate that some progress that has been made, particularly for the LGBTQI community, is being taken backwards? And we know that in spaces, particularly most of Africa, the health outcomes for them it's just bad because they are ostracized. And it has been stemmed by the superpower that their being is not, it's not there. What do we do to make sure that those who have got power get back to the right track, fully acknowledging that when you speak against them, they just say, hey, you're out.
Sure, I was trying to mute so that I can come back to you to respond to that question. And I would start by saying that it starts with agreements and policies. And anything that has not been put into writing, then it loses its meaning. And for us to see this kind of everybody being included, and I will not even mention, the LGBTI only. I'll also talk about the others also, because we do have interventions, but these interventions are led by institutions that have not aligned within the government structures. And if you look at countries that have progressed in regards to including, not leaving anyone behind, they have ensured that policies and guidelines are put into place that are taking into consideration everybody. So this is what I would be able to say. That's the first intervention, to ensure that we have this put into policy and into guidelines. Secondly, I would also talk about looking at the context. Contexts are quite different. The tailor-made solutions that have been made in South America or in Asia should not be cascaded to Africa. We understand what we need to do in Africa. So let's have solutions that would be able to go to the people within the different countries. As you well know, Tinashe, if you look at the northern part of Africa, it's not the same way as the southern part of Africa and the eastern part of Africa. So we need to really ask ourselves then, what can we do to ensure that we don't do copy and paste? Our key challenge is what is working elsewhere is what we are cutting and pasting to governments, and governments are refusing to adapt that. So can we start by looking at what we have? How can we make it actionable and workable within our context? And then from that point, we'll be able to see that being working. And that's what I meant with tailor-made kind of ways that are going to be more tangible and that are going to be more practicable as we do our work. Thank you.
Thank you, Dr. Mtuku. I will probably want to pick on someone who I know is a gender specialist to probably make a comment or a contribution to this, because I know she's been working in this space. And this is my colleague, Sion.
Sister, can you please repeat the question?
Yeah, so within the spaces of some of the conversations that have been discussed, or what we are actually looking at, how best can we make sure that we enhance these, or making sure that we get hold of these low-hanging fruits to tap into the issues of gender to improve the health outcomes?
I think we have to think about what we can do individually and as organizations. For me, always the first thing to start with would be a study, a basic study on the gender analysis, see where the gaps lie, and then coming up with the relevant policy and implementation strategies. So I feel like we are in a position to do gender analysis and whatever we do. And it's really impressive to see that we have people who may have leadership roles in their organizations and that can implement this, because political will is really important, right, for anything gender related to actually come to fruition. So yeah, use the power we have to start with an analysis and then a potential strategy or action based on that.
Okay, thank you so much, Sion, for that. Another person I know who works within this space, Prof. Nyepi, before I go to Professor Bukachi. Prof. Nyepi, your hand is up. Thank you, Sion. Professor Nyepi, please, you can unmute. Prof. Nyepi, if you are speaking, you are still muted, but I can see your hand is up.
Dr. Galinda, can I put Prof. Chimbaro on the spot while we wait for Prof. Nyepi?
If I may, sorry, we ran out of power, so I moved into my mobile. So it was giving me a bit of a challenge there. If I'm audible, the question that I have, perhaps maybe Dr. Bridget could respond to it, and possibly Dr. Mututu. I'm speaking to the issue that we should not cut and paste interventions from one place to another. And the question that I have is that oftentimes there's always a challenge in terms of knowing how different are we really, especially when you're looking at access to health. We basically need the same sort of services. Biologically, we are human beings, and socially we all have, I think all our rights need to be protected regardless of where we are. And when do we really have to say this is more than just cut and paste? When do we really need to know? What do we really need to say, or what is the line between cut and pasting and customizing in the context of dwindling resources, whether it's research resources, whether it's resources for services that we are providing? I'm particularly interested in the response from Bridget, particularly because of her experience in the area and the fact that you've been working across many generations relative to other junior colleagues in here. Thank you.
Thank you for this question. Thank you so much. Yeah, I mean, it's a very important question. We're always struggling with this issue. You know, as I was introduced as an anthropologist, and this orient indeed my way of thinking. So there is a dilemma between human rights and the respect of the people. So there is all this advocacy work that we do, sensitization. But at the end of the day, if you do not respect the other, if you don't respect the context, if you don't respect the people, they will not participate, they will not attend the meetings, they will not use the services. Okay, so anthropologists are there to try to deal and to negotiate those issues, to understand where is the line, where people are engaging themselves. And you need to have the people engage in whatever process. Even if it's a transformative, people need to be engaged. And when I say people, it's not a minority of few people. It's you need to have a participatory process where all the steps of whatever you want to do. I remember in some community having washing place for women to wash, their clothes instead of washing in their own house and carrying a bucket of water because of sanitation. And beautiful place were built, and the same for market. Beautiful place are built to help people to have a proper in bracket, a proper market, with cement table, with a shadow, so that they can have a permanent place and not being in the middle of the road, running after the car, also for road safety and things like that. But sometimes it fails. Often it fails because further discussion didn't start as soon as these ideas come. As soon as the idea of maybe we should build a proper permanent market, maybe we should build infrastructure for washing. People need to be involved. People need to be engaged. Is it a good idea? How do you see it? How it need to be built? Where does it need to be? How much is it going to cost? Are you willing to pay? Which price? You know what I mean? All this process is necessary. And this will be for everything. Everything. And in a specific context, it might work. And another context, people may oppose different arguments, different situations, and suggest different solutions. This is the beauty of it, because it's through this conversation that might seem a little bit lengthy and difficult and hazardous, but often you get the local solution for this discussion, and people will adapt, will build with you, and it's a creative process, but it takes time. This is a problem. Over to you.
Sure.
And
Let me
if I
add.
may,
Sorry.
may I follow up a bit? If I'm getting you well, the issue is not necessarily that the intervention will be different, but that the people would have had to have a say on that particular intervention. If that is the case, then I really get it. It's just that oftentimes, as I was indicating earlier on, the challenge has always been at face value, this thing was done somewhere else and therefore we don't want it here. But not necessarily on the substance of the intervention per se. Thank you.
I think you get me right. I mean, the objective might be the same, but the way you get there, the length is going to take, the people you need to involve, and the specific solution about the market. It's going to be very specific to the context. About the washing place, it's going to be very specific. People want it in that way, at that place, in this, and the discussion of the price, how much is going to cost, and who is going to manage this market, who is going to manage this this washing place. All those discussions might interfere and have an impact on the access and the use of those facilities. Over to you.
Thank you, Doc. Ladies and gentlemen, the conversation was getting heated and getting more nuanced, but unfortunately, the Earth hug is global. So we need to be moving to somewhere out of Africa. But of course, this space that we have been in, we have Dr. Halase to just give us, to tie down what we've spoken about, the key takeaways from this session so that we engage going forward. We know what to do from this space. Dr. Halashe, the floor is yours.
Thank you very much, Dr. Mutero. What a heated discussion and very interesting, I should say. Thank you very much to all the
Sorry, Doc.
panelists and everybody. Sorry.
Doc, my hand
Oh.
was up. Are
Okay,
we
Prof.
tight on time?
Kimberly. Okay,
Or
just
I'll
a
be-
few minutes, please.
Yes, I'd been put on the spot, and I really want to say this great stuff that has come out. But what I can say to answer the question of how can we make it happen, I take you back to my earlier presentation about the 6 pillars. So what I see is happening is that pillar number 2 on transdisciplinarity is not being fully implemented, because transdisciplinarity means walking the journey together, academics, non-academics, civic society. And we are not doing that. They are great specialists in gender and social equity, and therefore they are doing their work at that level. And we have engineers and we have biologists working with us, not transcending into those disciplines to understand and collect the correct data. So in a nutshell, I would say, let's move away from multidisciplinary research to transdisciplinary research, where we walk the journey together and collect the correct data. Thank you. Sorry to have taken you back.
Thank you very much. That was critical. It needed to be said. Thank you, Prof. Chimbari. And once again, I just wanted to say that indeed this is a heated and very interesting conversation that is showing us that indeed gender plays a significant role as a social determinant of health, influencing health behaviors and the response of or to health systems. And that also advancing gender equity and social inclusion in health requires integrated approaches that address social determinants of health and empower women and girls. And another point is that collaborative efforts across sectors and strategic investments in gender transformative responsive programs, policies and guidelines are essential for achieving sustainable health and well-being outcomes. But I'm not the one to actually give a summary of what has transpired thus far. I'm going to give my colleague, Ms. Njadimwe, who has been tasked with giving us or repertorying for us and giving us the summary of this session. So I want to give this time to my colleague, who's also, I didn't introduce her. She's a lawyer by profession, and she has volunteered to repertoire for us. So over to you, Manjadimwe.
Thank you very much. By way of brief introduction, my name is Uno Panjadimwe, and I am an attorney by training. I've been practicing for over 10 years now. And I have to say that I'm very happy to participate in this IFA-Health workshop because it aligns with another workshop that I took part in 2 days ago. It was an event hosted by the Botswana Stock Exchange, and the theme was how the stock exchanges in the SADC region can influence sustainable development of the environment and of the African people by using green bonds, and that these bonds should be aimed at investing not only in the environment, but in the people as well, by developing sustainable programs that touch on education for women, business, supporting women in business and supporting women's health. So I'm happy that the theme of my week is sustainability, gender equality, and equal opportunity, especially for women. Now, to summarize for today's session, I have noted the key points from the panel discussion. First, we're taken through understanding exactly what gender is. That is a social concept, a relational concept between men and women, and how these genders are perceived by society. We noted further that each gender is faced with specific challenges and different access to tools that help them with their challenges. And this includes the theme for today, which is access to health services. And the obstacles that were noted, I will just summarize, there were so many. but we noted that marginalized people usually cannot access healthcare services, mainly because of how they are perceived by the society and by the healthcare providers. We also noted another challenge that men, for example, are shy or uncomfortable to access healthcare services because it is associated in our society and community as weakness. Like you have to toughen up and you get better at home. Young individuals as well, especially when they go for sexual reproductive health purposes, are not usually received well at those centers. We also noted inequality with access to economics that would give is for access to healthcare. You will find that women are not empowered financially to access healthcare. They usually have to get permission to access healthcare. And we noted also inequalities in education. How do you know when you are sick? How do you know what you are sick with? How do you know to prevent getting sick in the first place? So there's inequality in education. And we also noted that especially predominant with women. There's also a discussion on what can be done to improve equal access to health. And the following points were noted. There were so many, I just picked a few, is that we need to intensify research on gender inequality and how it is linked to health inequality, and present scientific facts to decision makers and policy makers to make them realize that this is a real problem or that there is a real link between the two. And also we spoke of the need to stop normalizing some, healthcare abuses. I identified a lot with the abuse that we accept when we are giving birth. I think a lot of us women here will agree that we have normalized how how we are spoken to, how we are told, oh no, don't cry. This is not painful. You have to be strong. Like, there's no compassion, and we have normalized it. And it is painful because usually it comes from, a service provider who is a woman like you, who has been through it, and they know that it is a painful process, yet there is no compassion. So I think that not normalizing it and probably reporting it can also, improve the rate at which people are able to access the healthcare, or the willingness that they are willing to, access healthcare. And then there was also gender responsive budgeting, which was an eye-opener for me, that different genders require different treatments and they should be budgeted for differently. What the budget that is suitable for, male-related illnesses may be less or more than the budget required for female-related illnesses. And I also noted that they should not be gender biased in providing services. Why is pregnancy care only for the midwives or for women? Why are men not allowed to enter that space? Or why are women not allowed to enter other healthcare spaces? And just noted that we need a lot of education for both men and women, so that we can bridge the gap between inequality and access to healthcare. There was also a note on community-led solutions, that we need to ask the people faced with the problems what they believe the solutions should be. We shouldn't come up with solutions in our offices. We should do community outreach, do community surveys and interviews to get an understanding of, firstly, what the problems are, and then also what those people believe solutions that are suitable for them can be. And just also noted that government should take a lead role in addressing some of these gender inequalities by coming up with policies and programs. But there was a question on copying and pasting, that there is a lot of borrowing from other jurisdictions, things that may not necessarily work for us here. That as much as we benchmark, we should try and also custom make some of these policies for specific problems that we have in our region. And then there was finally a discussion on feminist principles and how feminism principles can be of assistance. And it was noted that feminism is about fighting for equality between men and women and all groups of people, and to make sure that men, women, and all these group of people have equal access to the same resources, that they have equal access to the same assistance, they have equal access to the same opportunities. And that also feminism helps with breaking power dynamics that we are faced with, our patriarchal systems. Feminism can help sensitize our communities that, you know, gone are the days of is one gender that is superior to there is a gender that is below the other, that we are at a place where we need to work together so that we are all healthy, so that we are all empowered, because it starts at the family. If the family unit is healthy and empowered, it spills over to the community, and then it spills over to as well. There were many points that were mentioned. If I say them all, it won't be a summary. So thank you very much for the invitation to participate in this. Like I said, it really rounded off my week because I have been participating in workshops that were really aimed at how can we improve the lives of our people, how can we improve the lives of women in our communities. So that is all from me in summary. If I've left anything out, I'm sure that someone else will add. Thank you very much.
Excellent summary. Thank you very much, Ms. Njadingwe. So I believe that ties it for everyone, even those who came a bit late. So thank you very much. At this point in time, we have been busy working. I'm hoping, Dr. Mutero, that the instrument is now working. So can you please get it to work and just do something for us? Thank you very much. As you are preparing yourself, I want to give Angel 2 minutes just to explain to people around here what is EarthHug. That's something that all of us should leave this platform with. Angel, over to you just for 2 minutes, and then we'll hear from Dr. Mutero. Thank you.
Yeah, sounds good. Thank you to everyone. I've learned so much during this session, so it's been so special. And thank you for the time to explain. So I wanted to honor Dr. Margot Parks as well. She was someone who worked with me back in 2022 to come up with the idea of EarthHug. And she was the chair of the EcoHealth International External Advisory Group. So just want to honor her. And really, it began as a space to foster this ecological and equity-informed innovation, integration, and global collaboration to improve health for all, which was work that requires not only knowledge, but also relationships and trust and deep care across regions, disciplines, sectors, and generations. And so it grew from the desire to create these connected and intentional spaces where we don't just talk about health and sustainability, but where we can practice collaboration and hold space for diverse knowledge and support each other. We often call it the EarthHug, as Prof. Chambari said, which is a reflection of what it feels like to come together across continents and time zones and lived experience, and really say that we're not alone in this work. In the world that feels very fragmented and overwhelming, we hope that EarthHug is a reminder that connection is a form of resistance, and that love and care and collective support are all these essential ingredients in building a healthier and more just and sustainable future. So we're really honored to be able to host it annually, and I feel a lot of gratitude for all of you to speak your wisdom into this space of collective action. Thank you.
Thank you, Angel. And Angel is the ECR, or Early Career Research EarthHug Coordinator. So we are working together with other great minds to come up with this event. So thank you very much. Dr. Mutero, are we ready?
Yet now?
Sorry?
Yes.
Go ahead, please. I don't understand why when you speak, we hear you, but then when you play, we can't hear.
I think I understand. We are not doing enough to hug the earth. That should be the only explanation. I can't explain anyhow because I'm playing. You see?
All right.
Just hit that box. Let's see what happens. Hit it with your hand.
Dr. Mutero, any chance you can join the meeting with your phone and you put the phone inside there while you're playing?
Yeah,
Yes.
that'll work.
Dr. Mazamba is actually a musician. He can sing for us. But let me try that alternative.
I can play the mbira. That's why I'm saying so.
I've tried to change every setting here.
Did you try joining with the phone?
And sharing the media as well, not just the voice. Share and share with the media.
Mm.
Okay. So as I do that, I think you need a gap filler.
Okay, true. Let's see. Hmm.
I think let's just continue. Maybe towards the end, he'll be ready. I really hope he'll be ready because we wanted to, you know, partake of this wonderful talent that he has. Now we are actually moving to the third session and the last session of our session. Yes, the last session. This one is a mini workshop. It's a mini workshop that is led by the ECRs, or the Earlier Career Researchers under EcoHealth International. And we thought that it's important for us to actually come together and teach the people that are here about EcoHealth approach. Not taking it lightly that some people who are amongst us do not have any idea about what EcoHealth approach is. But listening to the different conversations that have been going on, you will now get to learn what the approach is about and how it can actually help us to sort some of the issues that were raised up in our discussions. So I have different people that are going to be helping me. Firstly, I will just take you 10 minutes through the explanation of the EcoHealth approach, what it is. And then from there, I will invite my fellow early career researchers to come forward and share with us some of their work just for 10 minutes each. And then that way you can be able to see the importance of EcoHealth approach and its benefits and the impact that is having on the different communities globally. So I will now begin to share my presentation with us. Oh, wait, how do we do this? Maybe let me just open it on my screen, and then that way I can just share the screen. Just a minute. go. Pardon me, just a minute. I believe it would have opened. Hmm. Okay, so now let me just share my screen with us. Please let me know if you can be able to see my screen. Are we able to see it?
Yes.
Yes, it's visible.
Thank you.
If you can put it on slideshow, please. Yeah, I think it's good.
Okay. All right, thank you. All right, so I am going to take this time to just explain to us or define to us or teach us about the EcoHealth approach, which is very important, especially that during our discussion, we're talking about tailor-made interventions, research. So this is one aspect that most of us who are either working in the research field or even in our different fields, we should adopt to be able to come up with solutions that are tailor-made to the communities that we work with. Oh, let me remove this. Okay. So what is the EcoHealth approach? We are talking about a transdisciplinary research method that integrates natural and social sciences to understand and manage ecosystems and the interactions between human, animals, and environmental health. And it usually emphasizes on sustainability and socio-economic stability. I believe that even as we were speaking, you could hear a lot of these terms popping up through the different points that were brought up. And it's not moving. I don't know what's going on. Okay. All right. So the EcoHealth approach centers on 3 points that I'll mention. The first one, as we have even heard in our conversations, is the transdisciplinary point, which draws upon the knowledge and expertise from various fields to address health issues. That means that we work together in the different spheres to be able to address a situation. That includes even indigenous knowledge. It includes even the government, the civil servants, or the area, all the areas around us. If we want to come up with a solution that is going to work, that is going to help the people, we need to bring everybody together on the drawing board so that we gather all the expertise, all the knowledge, and bring it together to work for us. And then the other point is interconnectedness, which recognizes the interconnectedness of humans, animals, and environmental health, emphasizing that the health of one is inseparably linked to the health of the other. So as somebody who's working with the EcoHealth approach, you are very mindful that whatever intervention that you come up with, it should not affect the animals, it should not affect the environment, it should not affect the people. So everything should be balanced, everything should work together for the good of those three categories. And then the third point is sustainability and socio-economic stability, which promotes sustainable human and animal health and well-being through healthier ecosystems, while also considering environmental sustainability and socio-economic stability. So whatever that you come up with, it should not affect in the long run the people, the animals, and the environment. So the 6 different principles that drive EcoHealth approach includes a transdisciplinary approach or research, participation, gender and social equity, knowledge to action, sustainability, and systems thinking. And we will take each and every one of those and talk about them. So in terms of systems thinking, we are banking on the following concepts: that health issues being complex, that health issues are complex and interconnectedness, and we must actually look for the holistic approach when we are dealing with any health issues. So we recognize the complexity of health issues and that we need a holistic approach to deal with them. It also considers interaction between socio-economic and ecological factors. And then we also have transdisciplinary research, which is talking about research that incorporates collaboration across the different disciplines and sectors to address complex health issues or just any other issue. If I give you an example of a study that I have been in, we were looking at food security, but in diagnosing or working through food insecurity in a community, we had to engage different sectors or disciplines. For example, agriculture, we had to engage people who are working with the water. We had to engage people who are working with gender. So you can see the concept behind transdisciplinarity. You have to be able to involve different disciplines to address the issue at hand. And then participation is basically saying that we must engage communities and stakeholders in the research and decision-making processes to ensure that solutions are relevant and sustainable. Again, if I emphasize this point, it is key when you are working with EcoHealth approach that you involve your community. Even I can say that the community is allowed to teach you. So we put aside our intellect and then we say to the community, come and teach us. We have seen this gap, and now seeing it in your own eyes, what do you think is the problem? Because these people have been there forever. They know or they maneuver the problem. So it is up to us to be able to get information from them and see how we can link that with the research that we conduct and then come up with solutions that are relevant and sustainable. And if I speak to the sustainability part of the solutions, is that sometimes you may have to actually engage research assistants from the communities. And that way, even when you leave, you have people that are capacitated to be able to continue the work even when you are not there. Then on the principle of sustainability, it promotes long-term solutions that consider the environmental and social impacts of interventions, ensuring that they do not undermine the health of ecosystems or the well-being of future generations. As I have mentioned, it is important that whatever you come up with, the solutions that we come up with as researchers, they do not affect negatively the environment that we live in, the animals that we interact with, or even the people that are in those communities. And then the gender and social equity, which recognizes that health problems, as I have said, are often experienced differently by different social groups. And therefore, we must ensure that the interventions are equitable and address the needs of marginalized populations. And then the principle of knowledge to action. It is very, very key that whatever we come up with, the knowledge that we extract, the solutions that we come up with, we may be able to translate the findings into practical interventions and policies that can improve health outcomes. Gone are the days where we will just do research and then we just go publish in a foreign land where nobody even knows anything about that. And then the local community doesn't do anything about it. So we are saying, as researchers that are into EcoHealth approach, it is important that even when you begin, you know that there must be something that is going to benefit the communities after you are done. And those findings, the research findings, should be able to be translated into something that is practical and that can improve the situation of the communities or the health outcomes, as is the case of our topic today or theme today. And then I would have not done this justice if I leave out some of the sister approaches that are also very important and look somehow towards some of the aspects that I have talked about. EcoHealth, One Health, and planetary health. These are interconnected approaches that emphasize the interconnectedness of human, animal, and environmental health, but with slightly different focuses. So I wanted to mention this because amongst us, even amongst the organizers, we have people that are focused on some of these areas. So it is something that I have to do to be able to give us a fuller picture of these approaches. And EcoHealth, as I said, it focuses on the relationship between health and ecosystem, emphasizing the importance of biodiversity and environmental sustainability for human and animal well-being. Whereas One Health aims to address health challenges by recognizing the interconnectedness of human, animals, and environmental health, promoting collaboration across disciplines and sectors. And then planetary health focuses on the global health implications of the Earth crisis, particularly climate change and its impact on human health and in the environment. So as I have just explained it to you, you can see that all the three aspects or areas, they are talking towards the same thing, although it may be at a different concentration. So this is what I wanted to share with us to show us that, you know, EcoHealth International is a body that embodies an approach that can actually work for all of us. It can work for all the researchers. It can work for all the stakeholders. If we work together, bringing the different minds together to solve the different situations that we face, we can be able to overcome. We can be able to achieve a lot in these areas. We can be able to make a difference because we'll end up coming up with solutions that are relevant and that are appropriate for the different communities that we are working with. So this is all that I had for us in terms of this talk. And now following, I just want to invite to the podium some of my friends or colleagues who have done different works around the globe. And they will talk to us and let us know or show us the important work that EcoHealth does. and the benefits and the impact that they have done in the different communities. So without saying much, I want to call upon one of us, who is Ms. Tayon Johannes. Please forgive me if I butcher your name. I'm trying. But Ms. Tayon Johannes.
Can I interrupt you really quick? I apologize.
sure.
I'm wondering if I can actually go first, because I'm leading the next session in another hour and I need some time
It's
to
no
prepare,
problem.
if that's okay.
Okay, all right. In that case, then I will allow Dr. Yvonne Griffith, who works with the Department of Infectious Diseases and Global Health at Tufts University, and is currently in Kenya, actually doing some of the work. So maybe while I open up your presentation, you can just tell us a little bit about where you are right now. Thank you.
Yeah, thank you so much, and thank you for your understanding with with the timing. Yeah, so my name is Evan. I'm a veterinarian and a PhD student at Tufts University. Currently, I'm actually in Karamoja, Uganda. Beautiful Karamoja. It's pouring down rain outside, which is really wonderful. But most of my work and what I'll be talking about today briefly is in Turkana, Kenya, which is northwest Kenya, basically the farthest northwest part of the country. And I work with Turkana pastoralists around tackling, health challenges at the human-animal environment interface. Specifically, my PhD work is on developing a One Health assessment tool that's aimed at integrating data collection across all sectors, and also dissemination of that data. But today, what I wanted to talk about actually was a topic that's near and dear to my heart, which is an invasive species in Turkana called Prosopis juliflorus. And some of you who have worked in Eastern Africa and even parts of Southern Africa may be familiar with this tree. It's an incredibly prolific invasive species, especially across Kenya. So I'm just going to talk about that, some challenges and opportunities, and share a little bit about my own work on Prosopis. So if you can advance the slide, please.
I don't know what happens, but it will just.
Yeah, hopefully it'll catch up. Maybe I'll take this opportunity to plug the next session, which is in just over an hour now. We're going to be focused on systems thinking for One Health operationalization. And as Galassi just did a great job explaining, systems thinking is actually one of the principles of EcoHealth. So I hope that everyone can stick around and hopefully take part in that.
I'm trying, but it's not responding.
Yeah, I can share my
if
screen.
You have your
Do you want me to do
presentation, you
that?
can speak to it. Yes, you can if
Yeah,
if you are able to.
Yeah, let me see if I can. Let's see here. Are you able to see that?
Yes. Just put it on slide mode. Yeah.
Yeah. Okay. So everyone can see that, to confirm?
You can see it.
Okay, perfect. Thank you so much. So I'm just going to give a bit of an abbreviated presentation here, just due to the interest of time, but talk a little bit about the ecology of Prosopis, some of my work in Turkana, and then talk about some solutions, because as we know, EcoHealth is all about action and improving livelihoods and well-being. So Prosopis originally came from Latin America. There's 45 different species of Prosopis around the world. The one that I'm going to focus on today is Prosopis juliflora. It's among the top 100 most invasive plant species worldwide, according to the IUCN. We see that it's native, like I said, to dryland areas of Mexico, South America, and the Caribbean. And this is really an incredible plant. Its taproot can go 50 meters into the ground. It actually has some chemical defenses that it uses to outcompete other plants around it, and it's a really prolific pod producer. And so when we're looking at the distribution, you can see, especially in East Africa, it's really extensive. So Somalia, Ethiopia, and then where I work in Kenya, it was first introduced in sort of the southern part of the country in Tana River, and spread up into Baringo and Turkana as well, and covers at this point around 1.5 million hectares. And so in Turkana, in the local language, it's referred to as Edere, and it's ubiquitous. It's basically spread into farmlands, pastures, and along rivers and floodplains. And these are some of the pictures of the Prosopis thickets in Turkana. And so you can see from these maps, it especially likes where there's either a floodplain or along the rivers. So there's the Turkwell River, the Tarak, and the Kerio River. And all these are basically suitable habitat for Prosopis to spread. And so what I do, again, is just sort of focus on understanding the relationships between people, livestock, and the environment. And the methodology that I use for this study is something called fuzzy cognitive mapping. I'm not going to go into too much detail here in the interest of time, but again, if you're interested, we're actually going to learn how to do fuzzy cognitive mapping in the next session. So please join us for that. But what I was trying to understand here is basically what are the components of the One Health system in Turkana and how are they related? And so these were activities that I was doing with community members on the ground, doing these participatory mapping activities. And so what I've done here is just sort of zoomed in on Prosopis and kind of looked at the relationship between livestock, people, pasture resources, water resources, and how they're all related. And so what we see is that according to the community who are experts in this matter, as it of course impacts their lives on a daily basis, Prosopis decreases water and pasture availability through competition and suppression, also decreased access to water and pasture. So those thickets are so strong or dense that livestock actually have an issue even accessing the water source, like you can't even get through it. And similarly, and this actually goes to the gender issue, which is why I wanted to talk about this, women in Turkana are often the ones to fetch water for household use or water the animals. And they talk about how they also can't get through the thickets to get to water. And also they get these slow healing wounds that really don't heal very well. And so again, you're seeing how this is an eco-health or a One Health issue because it's impacting all these different areas. And so these are some of the quotes from the focus groups. The other issue with Prosopis, and you can see from this focus group here about the goat's teeth rotting out, is that when the goats eat the seed pods, it has a really high sugar content. So it actually causes the teeth to rot, and then the goats die because they can't eat obviously without teeth. So again, these are just some of the local voices and experiences around this issue that I wanted to share with you. So as a summary, it's a really big issue for women around fetching water and watering livestock, and even gathering firewood. In terms of livelihoods, it can be toxic to livestock. And as I mentioned, the pods can cause teeth to fall out. But there are potentially some positive aspects. So this one woman explained how we use it for firewood. We don't have a problem accessing Prosopis because we have the initiative to chop it down and it never runs out. We use our panga to cut them down. And so this sort of brings me to my next point, which is what do you do about Prosopis? There's some different areas of management around containment, control, eradication, restoration, and utilization. I think where I come at it and the conversations I've been having with partners on the ground is you're never going to get rid of Prosopis in Turkana. It's here to stay. So what are some solutions that we can implement to actually have a sustainable use of Prosopis that can maybe protect other natural trees that aren't being cut down for firewood and that kind of thing. So in terms of utilization, which is what I've focused on here, thinking about charcoal production or fuel wood and timber. And like I said, the native acacia trees, which are much more slow growing, there's a lot of deforestation happening. So maybe there's a way to utilize Prosopis in a sustainable way. There's some early attempts to grind up the seed pods and use that as animal feeds, which don't seem to be as toxic as if the animals are eating the seed pods directly. And then ecosystem services, you know, Prosopis was introduced initially to sort of do soil stabilization and erosion control. And we all saw how that turned out. It turned into be a terribly invasive plant. So I would say, you know, proceed with caution in terms of that. So there's a lot of work to do. And just again, to conclude quickly here, Prosopis is really a remnant and extension of narratives about pastoralists in East Africa as destructive. And so in the early 60s and 70s, NGOs were bringing in Prosopis because pastoralists are bad for the environment and causing, you know, degradation and all these things that we know aren't true, but that was the perceptions and actually still often are. We're seeing the ecological impact in terms of landscape scale changes across East Africa. We also see these changes exacerbated by climate change, so that's coming into effect. Obviously, loss of biodiversity, loss of ecosystem services when you're thinking about accessing natural resources, and we're seeing significant human and animal health, you know, impacts. And so again, the question that I'm sort of posing here is that Prosopis is here to stay, and so what we do. So the next step for me is to be working with the community and local partners on the ground and try to pilot some of these different interventions and see if we can make this a sustainable, you know, source of income and resource in the best way possible. So some resources there. I'm always happy to talk about Prosopis. It's somehow one of my favorite topics. And thank you so much for your time, and thank you to the organizers for inviting me to speak. Thank you.
Thank you very much, Ivan. Thank you for your work, for discussing your work. And as I've already mentioned, discussing the different principles, you can see that as much as he's working with One Health, there are still these principles being put to work. Principles such as participation, where the community is the key in coming up with the solutions and coming up with the information, the indigenous knowledge on what can be done. So here's the problem. The community also insight you on what could possibly be done to avert the problem. And that way you have a sustainable solution coming out of the whole interaction. Thank you very much. Next, let me call upon Miss Sion to the podium to come and share with us some of the work that she has done or she is doing. Over to you, Miss Sion.
Thank you so much. I hope you can hear me.
Yes, we can, clearly.
Great. And thank you, Dr. Chester, for bringing me into this panel. It's really a pleasure to hear from all the experts about, you know, the gender analysis, gender-focused work that has been going on. And I'm representing the University of Global Health Equity in this presentation, so I'll try to talk a bit about what we do at the Center for Gender Equity. And I'll try to bring in some reflections on how our work is aligned to the eco-health approach, maybe through the equity focus in our research and collaborations, and also the fact that we engage transdisciplinary teams in the research we do here. So just to give you some context, the Center for Gender Equity was established about 5 years ago. And as it is a university, our focus is more on academic and research activities. So we teach our students an introduction to gender and social justice, specifically for the medical school students. We also have a master's program on gender, sexual, and reproductive health. So during this process, our main aim is, working on research, focusing on health, and we go into a range of topics. We focus on teaching, of course, but also on organizational development, improving our organizational practices here. So when it comes to research, we are fortunate to have collaborated with different teams at UGHE. For example, just recently I was working with Dr. Chester on research on healthy aging, where we brought in discussions around gender, specific to delays in seeking social care and so on. So there is that kind of collaboration with different departments. We have teams working on with One Health teams on pork chain value analysis, and they have brought in a gender lens into that. That is still under process. We're also working with different teams, for example, student recruitment, registrar on barriers to females' access to medical school programs here in Rwanda. So through that kind of interdisciplinary approach, I feel like I may see the connection with the eco-health approach here. But beyond that, I also want to outline how we have tried to bring in a range of expertise in our gender audits at UGHE. So as you have been mentioning in the first presentation, gender analysis can be done at the community level when we are exploring issues to do with power dynamics, access to resources and benefits, and community needs and challenges. But it can also be done at an organizational level, right? So we have done a gender and diversity audit about 4 years ago, where we had brought in faculty as well as staff at the university, including students. And it was really a team collaboration to identify what we are working well at the organization, our organizational practices, organizational culture, what we should improve, what kinds of policies we should develop, and so on. We also engaged in a review of all the policies at UGHE at the time, which were about 89 policy documents. So for me, when you're doing gender-focused work, it is very important to, if possible, engage everyone interested and relevant for such study. We try to do that across the different programs we do. And specifically, organizational development should be done with that angle. And when it comes to global health issues at a university like ours, we talk about NCDs, mental health, nutrition, maternal health, and other SRH discussions that focus on needs and gaps, healthcare and treatment needs and gaps. So there is always that possibility to, collaborate with interdisciplinary teams. I'm not sure if you can hear me because there was a disconnection. Yeah, you can. Okay. So, for example, when it comes to, gender in global health, one thing we talk about is health gaps and challenge, right? But there is also a need to talk about gender equity in health leadership, especially in universities, academic settings where we see, less representation of women in, as first authors, researchers, or grant writers, or even PIs. So there are areas that I feel like we can do a lot more in terms of boosting research, as well as, bringing in more women leadership in the sector. Even academic health-related academic institutions, is there equitable leadership and engagement of different groups? That is also a question we have to think about and work on. When it comes to research, we also have to think about how well are women engaged as, editors in the journals that we're applying on, editors-in-chiefs. How well are women engaged in speaking opportunities at major conferences and so on. Again, my apologies for focusing on women on this panel, but I also want to give due recognition that in the gender, sexual and reproductive health programs that we have at UGHE, actually we focus more on inclusivity across all the academic programs. So we recognize that different groups of people have different needs and challenges. And among, the gender-related theories and frameworks, we explore our, masculinities and men's SRH, which I'm really happy about. So I want to emphasize that there is a need to do due recognition to the needs of different groups, even though I'm speaking a lot more about women's exclusion from these areas. So this is in short what we've been doing, but I feel like there is a need to do more. I feel like we need to also recognize intersectionality in whatever we do. For example, when we did the gender and diversity audit in the past, we did not really look into intersectionality and how, different forms of discrimination, such as race, class, socioeconomic background, disability, affect experience of inequity. And there is a plan to review our medical school curriculum with an intersectionality lens in the coming years. So that is in the plans. But overall, I feel like, we need to do more dialogues on this and develop our own discourse. And I'm really happy that I was invited into this platform. Thank you.
Thank you very much, Ms. Sion. I picked that, even in the educational curriculum, it's important that if we're going to do research, we look at cross-cutting themes such as gender, such as disability, to be able to pick out the right or come up with the right solutions, as well as coming up or involving the different disciplines. I think that's what I pretty much picked in what you said. So thank you very much for joining us and for being interested in participating. And next, I'm going to call upon Miss Irene Mutambo, who's also going to share with us some of her work. And I will try to share her screen. Her work, though I have been struggling, but I hope that it will work this time around. Is it? Over to you, Irene.
Okay, thanks again for this opportunity to talk about my journey as a professional career at the early stages of my growing. And my topic today is navigating the unknown, building scientific journey through mentorship and career guidance. I was already introduced. We go to the next page. Are you able?
Yes, I'm trying. Let's hope it will work.
Maybe I can try sharing from my side.
Please do if you can. Thank you. Oh, let's hold on. Okay, there we go.
Okay, so I'm going to talk about my journey as a young career scientist. And I have this title on me, the ice cream stand stall. A moment. So in this, it is a real life experience, a real life journey that I have moved ever since I graduated. So imagine this, fresh out of your first degree, standing at the crossroads, where your future seems unclear as the melting ice cream you're watching. That was me, starting my career at the ice cream company as a hawker with a symbol of uncertainty. I remember thinking loud, is this really for me? And this was it from school. I searched for jobs and I couldn't find any. So the available job was to go for ice cream selling. And this happens that I get an opportunity to land in IRI, that is International Livestock Research Institute, as an enumerator. So in this organization, I did a lot of field work, collecting data, analyzing, writing reports, and that is how I grew. So to me, the power of early career organizations is something like helped me to find my tribe. Though I wanted to be in academic world or research world, but I didn't know how to begin. So I define early career organizations as communities that are designed to support young scientists like you and me who is listening in today. And these are communities that help us to grow, that help us to learn and to connect, because in these communities we have diverse knowledge. We have researchers from diverse experiences, regions that can help us to grow and be better career scientists. And I've listed some of the organizations that have really helped, that I know are really trying to help young careers to grow and realize their dreams. Next slide. So I am the guiding light, mentorship as. So in this, in Erie, I found mentors that helped me now to realize my dream, that helped me to grow, and that I'm still growing. And through this, through award, we had mentor to mentee programs, and these researchers helped me to grow. In this field, we were asked to draw a purpose roadmap. What do you want to be? What are you aspiring for? What are the objectives that you want to achieve in life? And this my purpose roadmap was drawn in 2024. And I have a list of objectives that as a young career, I would want to achieve in life. I've checked some boxes, but some boxes are still unchecked, but I still draw back to my purpose roadmap to ensure that I'm able to tick each and every every box. So what is mentorship? To me, mentorship is more than just being a senior scientist. A mentorship is there to guide you. It is a source of wisdom. And I know most young scientists, you're not sure even of what you want to do in life, but through mentorship, you're able to grow and enrich your goals. We go to the next slide. So to me, mentorship is a two-way traffic, because we sometimes as young scientists, we like to be mentored. When you hear about mentorship, you want to really go for it. But sometimes we lack self-motivation. Sometimes we don't want to push ourselves. You're given an assignment and you're not able to do it. But we need to be, it has to be a two-way traffic. As your mentor is supporting you, try to support yourself. Show self-motivation. Show that you're willing to learn. Be respectful. Don't abuse the space that your mentor has given out to you. And push yourself from the comfort zone. Try to attend conferences. Go for webinars. Go for workshops. And don't be afraid to ask questions. I think I wouldn't be here today if I'm not self-motivated and I'm not able to push myself. And through this, you're able to learn. You're able to interact with professionals within your area, those that you admire. And if once you do that, you're able to grow bigger. And this is one of the photos that I took last year in South Africa. And I was still asking myself, is this really me? Because I wouldn't imagine being from an ice cream hawker to now being a PhD graduate fellow. Look for mentorship programs within institutions that you're working within and those that are outside you, because these will help you grow. And my last slide, it is a call to action and an inspiration. Take the first step. Explore early career organizations. Connect with your peers. Seek out for mentorship. Your journey is unique, like the way mine was unique. I don't know how about yours. I don't know how you began, but you don't have to walk it alone. You need someone to walk with this journey, because if you do not really have someone to walk with you this journey, You'll faint, you'll collapse on the way, you'll not be able to make it, you'll get disorganized, and you'll fall. And I mean, you'll not be an impact to the community or to your society. And my inspiration first today is, remember, every successful scientist, every successful politician, every successful scientist, every successful gender person that you're seeing today started where you are now. Embrace the challenges that you're facing, but learn from them. Don't lose hope and don't lose energy. Learn from them, because your potentials are limitless. Thank you for listening.
Thank you very much, Irene, for that wonderful presentation. I think it speaks to what this session is about, which is trying to lure the early career researchers to come and join such platforms such as this, EcoHealth International, where we have a lot of mentors, people who are willing to mentor the young ones. Ourselves, myself, Dr. Kalinda, we are a product of very awesome people in our midst, Professor Chimbari, myself, and Professor Nyepi for myself. So we are here because these people have taken it upon themselves to mentor us. It's not easy, like you're saying, but if you keep to it, you get to a point where you are now organizing such summits like this, but moreover, you actually get to learn concepts that allows you to do research in a dignified way, research that makes impact, research that helps people. So thank you very much for sharing with us. And then moving on, I was supposed to have a couple that were supposed to talk to us, Dr. Taranike, but I don't think they are here today. So we will move on to Dr. Chester Kalinda to also give us his part of the work, what he has done. Please share with us, Dr. Kalinda. Over to you.
Thank you so much. So hi, everyone. So within the space of EcoHealth, I think most of my works, I would say, have been done right within where I am in Rwanda, and mostly in Southern Africa, where I started my EcoHealth activities from when I was a student at UKZN. So I'll probably talk about some of the activities that we initially started and which we are currently doing either through our PhD students or some of our master's students. One of the things that I passionately talk about is about climate change and neglected tropical diseases. So it's raining quite heavily where I am, so you may get some noise in the background. It's because of the rain. And one of the entities that I passionately talk about is schistosomiasis, on which I have done some work, as well as other diseases. One of the snail-borne diseases that we are currently working on right now is we are looking at fasciolasis, which is a disease, or I would say a zoonotic disease that affects ruminants, hooven ruminants. But in some places, such as the Americans, it has been found to also affect humans. And within the space of EcoHealth, or using EcoHealth methodologies, one of the things that we have been trying to understand, just like we did when we were looking at schistosomiasis, is how climate change is going to influence the spread of these snail-borne diseases. Because as you know, these snail-borne diseases are very much dependent on the environment. So I would say that change in the environmental temperature has a greater impact on the transmission of these snail-borne diseases. For instance, if temperature or there is a slight increase or there is a slight change in temperature, or I should say increase, we find that the conditions that either favor the creation of environments that lead to the multiplication or the proliferation of these snails increase. And when we have more environments or more places or more areas becoming a lot more suitable for snails, which are often the vectors that host the parasites that cause these diseases, either being schistosomiasis, which is also called bilharzia, or fasciolasis, which affects animals. And then we have more areas becoming a lot more conducive, then we find that the risks of infections, either among animals or among humans, then increase. But what have we then been doing following some of the EcoHealth methodologies? We have been trying to engage communities to not only understand how they understand these diseases, but also try to understand from the indigenous knowledge systems how they help themselves, or how they're able to not only prevent, but also stay engaged to make sure that they stay abreast or know how to protect themselves. Some of the other things that we have been also able to do is to engage stakeholders, because we know that as much as we are from the academic side, it's also very important to engage other stakeholders, such as the communities and the policymakers. We also try to bring in then the policymakers on board to see then how best they can work with the researchers to make sure that the needs of the communities who are the most advantaged addressed, either through coming up with deliberate policies that lead to having their issues either relating to animals or relating to making availability of drugs, in the case of schisto, available to people, or simply coming up with other deliberate mechanisms to make sure that the health of individuals is improved. So these are some of the works that we have been doing within the space of EcoHealth. So over to you, thank you.
Thank you very much, Dr. Kalinda, for sharing some of the work that you do. I believe, colleagues, you can really see what is happening within the sphere of EcoHealth, that it is a very important approach for all of us to adopt, because going forward, we need it. We need it to make impactful work that will help our different communities to overcome different situations or problems that they find themselves in. With that said, I'll still call upon you, Dr. Kalinda, that you may just do an appeal for some of our youngsters here, or our young researchers to join EcoHealth. So over to you.
Thank you so much once again. So EcoHealth is a very big, interesting network that brings a lot of people together. Now, one of the wings where a number of us, I shouldn't say a number of us, but very few of us belong to, and which we probably may have heard of, is called the early career researchers. Now, I need to quickly point out that for the past 3 years, the early career researchers, including Angel, Carlos. Angel is from Canada. Carlos is from Mexico, but has been living in Canada. Galase, and then we have Ivan, myself. We have a colleague who is no longer part of us, but was engaged 2 years ago, Gabriela from NEO. I think she will be joining in the next session. Have been trying as much as possible to make this not only EcoHealth work, but this youthful or the early career. Last year, one of the things that we did is to look at all the activities that we have been doing as EcoHealth, and then we came up with something very interesting. We decided to put all the previous sessions or all the previous EarthHug activities we've been having on a Padlet. And we have also, with the help of our mentors, written also a paper on this, which we hope that we'll be able to share soon when it's published, of what we have been able to achieve within this young group of EcoHealth researchers. But within us, we believe that we can actually do more if our networks, or not only our networks, but if our group grew those of us who have been active. Of late, a number of, or I should say, when we started working on EarthHug, we tried to, as much as possible, our colleagues from various places. And this year, we've been able to get colleagues from Southeast Asia, such as JP. We have Chanya, who will be joining, I think, in another session, in order to simply make sure that the works of EcoHealth and of the early careers are really ahead of and are really broadcast to appeal to every one of us, especially the early careers who are attending this conference, that it would be very great and interesting of you if you could join this youthful wing of EcoHealth, which is trying to make sure that we grow just not beyond, we grow beyond what we are and begin. Some of the ideas that we currently have are things such as beginning to apply for grants. And of course, we will be doing this with the help of the mentors that we have. We again want to continue having these EarthHug on an annual basis. And the only way that we can make them a lot more exciting and a lot bigger than this is by having more minds and more people come together. So I would like to appeal to each one of you, especially the early careers, to join this youthful or the early career wing of EcoHealth to make EcoHealth a lot more interesting. And I would like to also invite you for the next session that will be starting at 3, that will be spearheaded by our colleagues from Europe. Back to you, Galase. Thank you.
Thank you very much, Dr. Kalinda, for that appeal. Indeed, we do need more members. And one thing that I have to say is that currently we have done away with the joining fee for a while. So you still have the liberty to join now for free. So we are available. You can get in touch with any of us. As you have come here, you received an invite that has the community WhatsApp group. So you can either come on in there, and if you've been invited by any of us, please talk to us if you're interested, and then we will get you on board. So thank you very much, Dr. Kalinda. With that said, we have actually come to the end of our event. And at this point in time, I'm going to call upon the Africa chapter chairperson, Professor Nyepi, to come and give us the closing remarks. Over to you, Prof.
Thank you so much, Dr. Mupimwa. Am I audible?
Yes, you are.
Great. At this time, I'm really honored to proffer a vote of thanks for such an insightful and engaging event. I'm particularly proud that this work has been done purely by the efforts and of our early career researchers under the coordinatorship of Angela. And in particular, as the chair of the African chapter, I'm proud that we've had one of our own in the names of Dr. Ramolefe as well as Dr. Kalinda, really working actively to bring this event to what we have witnessed today, a very momentous event indeed. I wish to particularly share my heartfelt appreciation to all of us who are here. Our keynote speaker, who is very well established, a woman with a lot of clout in terms of issues of gender, to particularly appreciate her sharing with us the expertise and thought-provoking address, the insights that she provided that help us appreciate that everything is gendered. Definitely, she's not alone in this area. We have had wonderful speakers in terms of our panelists and our moderators for the panel discussions, who have allowed us to learn perspectives that we would not necessarily have appreciated without them. We're particularly happy that we've learned a number of gender-friendly tools that can be employed as we do our transdisciplinary research. We want to appreciate in the greatest extent possible the chair of the EcoHealth International, Prof. Chimbare, whose leadership has led to this sector called the early careers. He is really big on mentorship, and I'm really happy to have been benefited in part to his leadership as well. As the chair of the African chapter, we're particularly proud that as I was looking at the discussions, at one point, I think around 1:15 our local time here, there were 52 people registered on this platform. And many of those were within the African continent, which is really what we've been trying to reach as the Africa chapter. And so we are happy that they've got the opportunity to listen to all the wonderful presentations that went on here. They've had the opportunity to reflect with us as we deal with an issue that is so close to our heart. I was asking a question earlier on with regards to the issues of interventions in gender, because as a continent, we have a really unique and serious gender issues. There is a lot of inequity in pretty much all the services that we have. Access to education is gendered, as we've learned, access to land, access to health, and all the social economic issues that every individual needs to have to thrive are gendered. And so our panelists, our moderators have done an excellent job in bringing these issues to the fore. And they do so in the lens that moving on from here as a chapter, we will be beginning to be thinking about our research in a manner that employs these tools so that we leave no one behind. We do not leave people who are different from us. We don't only look at things from our own lens, but from the diversity of lenses that we have. In the diversity that we have in terms of scholars, the disciplines that we have here, the recognition of the solutions that the communities in the African continent have and can share, and we can learn a lot from them. And so we've really been benefited tremendously from this presentation. I feel like our early career researchers have really selected a topic that resonate with many of us in the continent. I want to appreciate my deputy for inviting you to join the African chapter. And I cannot underscore what he has talked about. It's particularly important that we benefit from working collectively as a team, from a diversity of disciplines, from different ecological areas, geographical areas, political areas within the African context. Many a times we have had situations where we said solutions have been imposed on us. Here in the African chapter, we do not want evermore to be playing that song, because we have the tools that we can use to be part of the people who develop solutions for ourselves. I do not believe that we are less gifted intellectually than other parts of the world. I do not believe that our resources are such a huge constraint to proffering solutions to the challenges that we have within the African continent. And so I want to join Dr. Kalinda in really welcoming you to the African chapter and extending an invitation to you. I'm particularly happy that Dr. Mutuma also mentioned that membership is free. This is because, you know, being an infant organization that was formed in 2018, COVID did not give us the opportunity to follow through with our plans, because shortly after that there was COVID, and it had massive impacts on our processes as well as the economy as you know it. And that is why we decided that our membership will be free. And we believe that in the near future, we'll be coming to you to present to you the opportunity to come and be with us in an international conference that will address issues of African concern. Certainly, gender is one of them, but is not the only problem that we have. And so we're calling all of us to come and wrestle with a lot of these issues and bring to the fore solutions that we know are culturally appropriate and will therefore more likely be able to work and solve our problems. It's always a challenge to give a vote of thanks, because in doing so, sometimes you leave some people behind. But I want to say to all of us here present that you have really contributed immensely to the work that we have benefited from today. And I want to urge all of us that we are going to be providing similar engagements, webinars, workshops, and then early next year, an international conference that will be held in Southern Africa. And so be on the lookout for our invitation. I'm reminded that there are some people that always work behind the scenes to get the work done. And I know that our early careers did an excellent work, but I also know that the Secretariat also has had an input in terms of making sure that these invitations reach many of us in different African countries. And so I really want to appreciate our Secretariat for such an excellent work. Thank you all. Thank you, colleagues. Thank you so much. I cannot underestimate the work that you've done. History only will remember many years that this was the beginning of great things in the African chapter. So thank you so much. All the best. Let also be ready, some of you who have the time, to please also join the next session. It's important that we work together. It's an earth hug. We don't only listen to the African chapter session, but you also support other sessions as well. Thank you. Thank you so much. God bless you all.
Thank you very much, Prof. Nyepi, for that vote of thanks. Before you leave, please, may every one of us just put your videos on, please, so that we can do an earth hug. There will be a picture that will be taken that will actually be shared. So please, let's all of us turn on your videos. And Angela, are you there? Is she here?
Yes, yes, I am.
Okay.
Thank you. Okay, so I'll count down and then pause for an extra second because it takes a second to grab the photo. Okay, I still see photos coming on. Perfect. Okay, so 3, 2, 1. Perfect. Thank you so much, everyone.
Thank you very much. Thank you everyone for coming. This is the end of our session, and as it has been said, the next session is upcoming, so please find time to go and support them as well. We are still one, though we are in different regions. Thank you very much. Bye.
Thank you. Bye.
Thanks, Glossy. Thanks, everyone.